you'll find a QR code right in front of you, either in one of the stands or flat on the table. Post your comments, ask questions, and drop an emoji about what you feel about today's event. To get you acclimated to using our conference forum, which is a live conference forum, we added a poll there. So there is a question when you sign up, and it's very easy to sign up. You just write your first name, your last name, create a password, and you sign up. And the poll on there states, what generation do you identify with? So we'd love to find out what generation you're about. I'm middle-aged. Does it show that? All right. But we want you to be a part of the ongoing conversation throughout the day, during and after each and every session that you hear. All right, now I have the distinct pleasure of introducing a 2025 Pride Trailblazer Award recipient and the director of the New York State Department of Health Institute, AIDS Institute, Joseph Kerwin.
Thank you, Beatrice, and thank you for that acknowledgement of where we are relative to Stonewall and everything that's happening this month. Good morning, everybody. On behalf of the AIDS Institute, I'd like to welcome you all to today's conference. I want to acknowledge at the start the support that this event receives from the Conrad Hilton Foundation in support of today's event, and certainly we appreciate their resources provided to us to put this event on. I also want to start by acknowledging my thanks and the leadership of our medical director at the AIDS Institute, Dr. Charles Gonzalez, in which, very humble. Charles, make sure you let me know which generation you fall into when you fill out that. And our digital health initiative team, led by Dr. Smith and Dr. Aladdin, and the team that works to challenge us all within the AIDS Institute to be current and up to date in the utilization of digital tools for our work across our portfolio, as well as promoting those resources to our partners and collaborators within the community. They keep the agenda and the issues alive for us, and I personally am very grateful for their work within the AIDS Institute. And they are one of those groups that takes a little bit of resources and goes a long way to do a lot of stuff. And as the director, I'm especially appreciative of that. So thank you to the team. Digital health is an essential strategy for organizing this event. And this initiative provides leadership in the development, research, and integration of digital tools into our educational efforts and our program activities. Digital health is an essential strategy, and the AIDS Institute has long supported this effort, including HIV self-testing, telehealth, social media educational campaigns, and the medication for substance use treatment and electronic referrals, or what we refer to as the MATTERS program. This program partners with providers across the state to rapidly link individuals with substance use disorder to treatment and resources in real time. The theme of this year's Digital Health Conference is Navigating Digital Health Across the Age Continuum, offering an opportunity to understand how digital solutions address unique health challenges faced by different age groups, and emphasizes the importance of bridging the gaps across generations in the utilization and the access of those tools. So as we hear today, the various sessions highlighting the latest tools, innovations, and resources, let's remember why we're here today, and that is to improve the health and bridge the gaps to improve ultimately the health of New Yorkers across our state. Let me end by saying that on behalf of the Health Department and the AIDS Institute, we want to thank you for your continued effort and dedication to the work that we do in these very challenging times. And as Beatrice noted, our mission at the AIDS Institute and the mission of the Health Department has not changed, and it is certainly our intention to continue to partner with all of you to further our work and our effort going forward. So thank you for having me today, and I look forward to the rest of our conference.
You're taller than me. Thank you, Joe, for those opening and welcoming remarks. So next up, to help frame the day's conversation, I'm honored to welcome our next speaker, who will provide an overview of today's conference theme. She'll explore how lived experiences influence the acceptability of digital health tools, along with the ethical considerations that must guide their design and use. Please welcome, in joining me, Dr. Julie Chakuji. Yes.
Good morning. Hello. Thank you so much for being here, and everyone in person and online, I believe. I am a former employee of the National Institutes of Health, now an independent consultant, and my expertise is in the ethical, legal, and social implications of emerging technologies. So digital health tools are really transformative, and they really offer great potential for expanding access to health information as well as personal monitoring. Let's see if I can do this correctly. And maybe? No? Sorry. I can keep talking. I know we're short on time. Yes, perfect, thank you. So first, we're going to begin with discussing the background in which digital health tools exist, and then we'll go through some of the tools themselves, and following that, we'll talk about how life course and lived experiences impact the acceptability of these tools and some considerations. Recommendations will be woven throughout the conversation, but we'll also do a little summary of those. So digital health tools do not operate in a vacuum. In fact, they're actually part of a much bigger vacuum that is seeking to suck up all of the data it possibly can. And so we need to remember what else is going on when we try to evaluate digital health tools. And so we'll go through a little bit about what other data is being collected, how it's being stored, used, and shared. So few people really are aware of exactly how much information is being collected about them. And the people that are collecting and then actually selling this data, they're called data brokers. And you'll see that they are collecting everything from your name, social security number, your contact information, your financial transactions, that's itemized, as well as real-time location. They are collecting history on your health status, whether it's your insurance claims, medical records, as well as I can't actually see it, but that last one. And so much of this data is actually individually identifiable. And this data is coming from places like your phone and your laptops. A lot of us kind of like to forget how much data is actually generated by our phones, the phones themselves, but then also the apps that we are installing are also generating and sharing data. And they're actually not necessarily just collecting the data that goes into that app, but they might be reaching across apps and taking data from your phones. There's another big bucket, which is kind of anything connected to the internet. So these are things that you might have in your house, like a thermostat. Those can actually monitor the activity of the house and actually know how your patterns and when you're regularly home or not, so that's creepy. And then you have all of your voice-activated tools such as Alexa or Siri. Those have actually been known to capture personal conversations. And then Wi-Fi, something that we really kind of take for granted. Probably all of us are aware that public Wi-Fi isn't secure, don't want to transfer a lot of personal information, but Wi-Fi can actually be used to see through walls. And I realize that sounds unhinged, so I bring receipts. So there's a lot going on in the background. And we also are seeing, sorry, catching up. Not used to doing this with paper. There's other sensitive data that can be collected. So if you've ever purchased a test to find out your ancestry or perhaps learn about your genetic risks for disease, unless that test actually required a doctor's order, they can be selling your DNA and any other health information that you share with them to other companies, and that can be either what they call de-identified, which I don't believe in. If you want to talk about that another time, we can do that. Or it can actually have your identifying information. We also have health data and AI. AI's main goal is to suck up as much data as humanly possible and machinely possible in order to improve its models. And so often that is not with consent. They're not paying content creators usually. But you know, we all are normal, we love convenience. And so a lot of times we look at it as a transactional trade of, I'm getting a service, it's a free app, whatever it is, free service, and I like it, so I share my data, and that's kind of the cost of it. And so the real thing I want you to take home from this section is who has access to your data? And it's not just these companies that are buying and selling your data, but this was just from a couple weeks ago, and you've probably even heard more recent news about how the government is actually also buying our data. And this is the intelligence services are actively seeking personal data of Americans to use against them. So the next section, we're going to talk about the various digital health tools. These include health apps, wearables, telehealth, and electronic health records. The first group, I'm putting wearables and health apps together because they share a lot of similarities. Most wearables have an app that you install on your phone so you can track it. And so these are going to be actually capturing everything that's coming from your phone, as well as other data that you might not think about, like location data, your movements, what web searches you're doing, and everything like that. The other bucket is the telehealth. Oh, sorry, I'm off a slide. So there's a lot of concerns for privacy and surveillance regarding the health apps and the wearables. And this is an example of a wearable. I'm by no means promoting this company at all. I just want to show you some of the information that they claim that they can collect from a skin sensor. And I've put stars on some of the things that raised my eyebrows, such as being able to infer your emotional state, your cognitive status from a skin sensor. They're capturing your gestures and arousal. But the point of this is that, for example, if you were in a car accident, whether it's your fault or not, and you're wearing one of these types of sensors, I highly expect somebody would find that out and want to collect that information in order to prove that you're guilty, whether or not you are. So things to consider. And then we have the other bucket, which is telehealth and electronic health records. These are grouped together because they have similar legal protections. You've probably heard of HIPAA, the Health Insurance Privacy Act. I'm not getting it right, sorry, Portable Privacy Act. But anyways, when you go to a doctor, you sign a form and they tell you, they disclose to you how your information can be collected and shared. But what they're not necessarily saying is that there are loopholes where they are able to, quote again, de-identify your data and sell that information. So these are some risks. The main concerns with these are very similar to the wearables and health apps, although surveillance is not as important in this group, although the risk is never zero these days. And then we want to talk about how digital health tools really vary across generations. And we hear a lot in the literature about how younger generations are more likely to adopt digital health tools and older generations have barriers to accessing these tools. So let's unpack it a little bit. For the younger generations, one thing that's really important to consider is consent. Until the age of majority, which is usually 18 in most states, participation in research in particular is going to require a parent or legally authorized representative to consent for them. Some places, if you consent under the age of 7, you might not even realize that you were in a research study. So it's really important for researchers and health professionals to maintain regular engagement with participants that were enrolled young, and regularly reaffirm and ask for assent that they do want to continue to participate in these studies. There's also the kind of normalization of sharing information publicly about oneself, and that can lead to a risk for decreased vigilance about data sharing, so making people a little bit more likely to be exploited because this has been normalized. On the other hand, we don't really hear talked about a lot is for these younger generations, they have a life experience of families sharing information about them without their consent necessarily, and already having a lot of their information publicly available. So that can also take a new shape, that when given the opportunity to consent for data collection and sharing on their own, they may actually want to restrict that as much as possible and kind of take that control back. The other end of the spectrum, we have the older adults. We know that there's a lot of accessibility issues, so using the phone's accessibility tools can be very helpful, but we also know that from the literature that older adults may be less trusting of the data that the apps are generating. They might not be very interested in learning about a new technology, and they might not feel comfortable in their ability to learn about a new technology. So if you're focusing research with older adults, co-design is going to be your best bet. You want to really understand what the community's needs are, tailor the education, simplify it as much as possible, and think about things like making sure that there's a web login, so somebody that's more comfortable using the internet as opposed to an app on their phone has multiple avenues. And if you're focusing on a certain disease condition, it's going to be more important to focus, to work with that group so you understand what kind of negative psychological effects might arise from that constant monitoring. You might be reminding them of all the things that they've lost over the course of this disease. And different diseases are going to have different types of impact on their ability to use the digital tools. So we hear a lot about the younger and older generations, but what's going on with the middle-aged generation, which I identify with? So this group is most likely working full-time. They probably are statistically likely to be having to take care of families, whether it's children or parents. And like the younger generation, they're probably pretty comfortable with digital tools and apps. The convenience of it is wonderful. But they might also be having decision-making fatigue by working and doing all of these things. So they could also be very vulnerable to that data exploitation because they're busy. They don't want to read all the terms and conditions. I don't think any of us want to read all the terms and conditions. So they might be more inclined to want kind of like the bottom line up front summaries. And so it's really important when you're talking about consenting for research, if there's a third-party app that you're using, maybe summarize those terms and conditions so that you're still giving that information in a more accessible format than what the company might be giving. So high level for generational differences, I'm kind of short on time, so I'm just going to say work with your communities to co-design these things. And then moving on to sensitive contexts. So we've made a lot of great progress over the past few decades. However, we've seen a huge backslide in who would be vulnerable to stigmatization, discrimination, and surveillance. That list is sadly growing every day. And so we really need to think about who is and isn't being included in these studies and these and what kind of information we're asking for. So for example, anybody that migrated to the United States, regardless of their legal status, is sadly now a sensitive group, and they're vulnerable to surveillance. So if you're collecting location data, country of origin, anything like that, you want to really treat that as sensitive data. You want to keep it encrypted, and if it's not actually necessary for your study, it's probably best to just not collect it at all. That extends to activists and women that live in states that have outlawed abortion. Location data is going to be extra sensitive. We also have anyone who is gender diverse, gender nonconforming, and collecting that information, again, is very sensitive. I would highly recommend not sharing that with any federal agency, funding agency. And also be really mindful if you're sharing that kind of information with private companies, as they are also selling that data. And then, no, there's more groups that I wanted to talk about, and I have lost my spot. Any medical conditions, mental health conditions, those can be very sensitive. We've come a long way with destigmatizing AIDS and HIV, but it is still definitely a condition that you want to treat as sensitive data. Mental health monitoring can also reinforce mental health stigmatization, especially for apps that have community forums or have unregulated content. There's also bias that the algorithms can pathologize normal adolescent behavior. So you want to be very cautious of that. Whenever possible, use technologies that have clinicians or fall in that telemedicine kind of bucket, as they're going to have better content and moderation of data. And then we also have a growing trend of using digital health technologies for substance use disorders. And obviously this is a very sensitive category of information, but for the researchers in the room and potential participants, you want to think about what kind of information are you actually gathering and how are you going to deal with that. So for example, if somebody has a history of substance abuse and you're collecting location data and heart rate data, you might be able to witness an overdose in real time. Is that something that you are going to intervene about? And if so, how? In intervening, is that going to result in the police being called? If you're not monitoring this in real time, that needs to be planned out. So these are things that you need to consider and really make sure that you're addressing in the consent forms. Similarly, information about blood alcohol levels, if you have like a wearable that's tracking how quickly somebody's moving, that information, we want to encourage trust in research and we want to help protect health. So things you can do are get like certificates of confidentiality, which will protect you from having to share research data if you're subpoenaed for some legal court case. Those have been upheld by the courts, but there's still some pretty broad buckets for which the certificates may be excluded. So it's something to consider. Other considerations, we know that wearables were not inclusively designed, so darker skin tones don't necessarily work. Rural populations, telehealth is wonderful, but if they don't actually have a hospital nearby, it can only bridge the gap so much that they may still have restricted services. And then, with that Wi-Fi not being secure, you want to think about your population. So maybe older adults and people on fixed incomes don't necessarily have their own private internet. They might not even have smartphones. So making sure that you plan accessibility in. The other thing to consider is who's being excluded. So if somebody's in the foster system, being able to consent them into a research study can be really difficult based on whether the parents still have rights or if they have, if they're technically wards of the state. You might need to find their parents to give consent. You might need to get a court appointee to provide consent. And we really want to make sure that these technologies are helping everybody, including the most vulnerable. So really putting your protective hat on is going to be very helpful. And then, so highlights of the recommendations. The basic takeaway is you want to be inclusive, design your studies and your use cases with the communities of interest. Co-design is always going to help you identify your blind spots and what is and isn't important to the community. You want to limit the data that you're collecting to that which is absolutely necessary. And whenever possible, use contracts, the contracting process for what data is collected, stored, shared, used, sold by third-party companies. So if you're using an AI device or app, you want to use that contract to make sure that they are not retaining any of that data, especially with mental health conditions. And the business agreements do have this zero data option. However, being able to enforce that or oversee that is a huge limitation. And then you wanted to do your best to make the information as accessible as possible. And so, like I mentioned, if you can summarize any other company's terms and conditions to make it a little more approachable, understand if you aren't able to limit the data that they have access to, understanding how those companies are going to use it. I was recently part of a study where we tried to use what we called data flow diagrams in order to convey all the different groups and companies that are getting your information and how that process looks. It's still complicated, but it can be really helpful in just opening the conversation about how your data is moving around, who has access to what, for what reasons, and for what length of time. So I think I did it. Came in at time. Yay. So as I mentioned, I am an independent consultant, and I'm more than happy to work with community groups, citizen scientists, and offering deep discounts on anybody whose research was affected by this administration. So do feel free to come and talk to me. You're also welcome to call me Julie, because my last name is impossible to pronounce. So thank you very much, and I'm happy to take questions. Don't be shy. Data's fun.
So we invite everyone in the audience who has a question to come up to these two mics and ask our wonderful speaker, Julie, anything that comes to mind.
Thank you.
Hi, David Rosenthal from Northwell Health.
Hi.
How are you? Thank
Good,
you.
thank you.
So one thing we've been thinking about and actually working on a little bit is what data are we transferring to the RIO? What information is going to the regional healthcare exchange? How that information goes. Currently, it's under state guidance and state supervision. There's been some discussion about possible federal oversight or federal acquisition of some of that data. We're particularly worried about gender identity, sexual orientation data, pronouns, and information like that, and we're working on trying to restrict some of that. Could you speak a little bit about kind of where we are with the RIOs within the state of New York, how that data is kind of moving, and what kind of protections we have against federal oversight of that data?
I can't specifically speak to New York State. I'm actually from San Diego. But I can say that for all local and regional offices, data transfer and the involvement of the federal government has certainly taken on a new dynamic. It is important. I mean, I love the CDC and the NIH, we're used to. And so it is important that we do kind of plan for, interoperability, ideally, but it's also really important right now, especially with gender, that we are mindful of this is being weaponized. Like, let's not kid ourselves. So one thing I would recommend for your team is to consider other measures that might help get more at the root causes. One thing to consider would be the everyday discrimination assessment. So really kind of understanding what the experience and the impact of the experience is. And that can be for gender, it can be for race, ethnicity. It really captures a lot more than just the demographic data that we typically control for. Helps to get to some more underlying issues. You have follow-up?
Yeah, I do. So I guess I think collecting data at the individual site is clearly critical for both research and clinical care purposes. I think the question is as much as we've been pushing towards interoperability for medical records and things like that, the question is what data should institutions start considering to not consider interoperable outside of the context of, if we're not in a specific research protocol that allows for that interoperability, I think that it's critical that we do have exchange of information. If someone shows up at one institution with a heart attack, we have to know their basic medical information. The question is the information specifically around gender or around abortion care, or those kinds of issues, are those items that we should consider at our various institutions to possibly remove from the interoperability format, even though we can keep the data in an interoperable format? We just remove that from the HL7 stream, so we're not putting those individual demographic data pieces through.
It's a huge issue that we're dealing with right now, and I love data, I love science, and I want to promote health research, but I also want to be protective of the individuals. And so it's kind of a case by case that I would say. New York is more open-minded, but you also have to think about what happened with like Vanderbilt Medical Center. They were subpoenaed by the state legislation and then by other states to find out who is having transgender care. And so making sure, I guess, that you would work with your legal department to understand what the limitations of protecting that data are, what kind of contracts are in place with the groups that you're sharing the data with, that you're all on the same kind of united front to make sure that that data is secure and protected. And if you can't get there, then it might be worth excluding those specific things, but again, working with the community to identify other ways that you can capture that experience without putting them at risk for stigmatization or worse.
Thank you.
Thank you. Great question. Hello, sir.
Hi, Charles Gonzalez, the AIDS Institute. Other than Pfizer court order, who has access to the information stored on the servers? Because although you may have consent decrees that certain information is not shared, it's still there.
It is still there, and we've seen countless hacks from hospitals to corporations. It's pretty much safe to assume that nothing's really that safe. And so really, especially with the sensitive data, you want to use tools like encryption as much as possible, secure end-to-end communications so that the data isn't getting swept up in the data transfer between groups. People are really excited about blockchain. I don't actually think that's necessary in most cases. Happy to talk about that at length offline, but it's going to be a huge resource and kind of drain on your budget, and regular encryption should be sufficient. But I think that we need to acknowledge that there are bad actors in the world that are actively trying to get and manipulate and use data. So protect it. Hi.
Hi, Mike Clifford from the AIDS Institute. Great presentation.
Thank you.
So I was thinking about all this, and I know that we do a lot of like SurveyMonkey things, like for everything we do.
Right.
And so I'm just trying to wrap my head around that, and like, you have advice for like what things to ask, because some of the questions we do ask, I guess, are, personal related, and so I just don't know if that's a real secure place to do it, or
Yeah, you'll want to look at the terms and conditions for SurveyMonkey, but another alternative, I do not work for Vanderbilt. I have no affiliation with them whatsoever, but they do have a great resource called RedCap that is free for private, yay, RedCap, another nerd, yay. It is free for nonprofits, academics, health, public health, et cetera. And you can develop your own surveys there. It's super easy, like drag and drop kind of stuff. And it's HIPAA compliant, so you're gonna have a higher level of security with that. They're not accessing your data, you own your data, you store it locally. So that's one of the great ways to do it. And then making some of those more sensitive things optional, just like, it is handy to have this information, but you can actually mathematically back into, if people are withholding information, that might actually help you to understand the sensitivity of that. You're not, obviously you can't say you can't identify them as something that they're not self-identifying for, but it can be very valuable to see what information is not being shared. So that's another way to kind of get around it. But whenever you're using a third-party company, especially for-profit, just assume that they're keeping it and selling it and using it.
Thank you.
That's a good baseline. I think we're out of time. Thank you all very much. And don't know if I'm passing. Okay, super.
Hello, let's give Dr. Julie another round of applause for piquing all of our anxieties and addressing the bear in the room or the elephant. I can't remember which animal that's supposed to be. But hi, I'm Mark Thompson. I'm a member of the Digital Health Initiative, and we're really happy to have you all here. Our next slide that should come up now would be fantastic. Will be about engaging and empowering youth and with digital health. Oh, you'll also notice the comic book characters that are on the slide. They're from our digital comic called Tested. If you scan the QR code, this takes you to a season about healthy relationships with youth. The male character actually grew up in the foster care system, and so it explores how that experience impacted the way that they interact with the relationships in their lives. And we talk about HIV and a lot of really cool things. We'll talk a little bit more about the comic after a couple of different sessions here. It's also my pleasure to bring up Dr. Morell, who will be leading a panel about youth interacting with chatbots, the good, the bad, and the ugly. If Dr. Morell could please come up.
All right, hello everyone. My name is Dr. Kelly Morrow Jr. I'm an assistant professor at the University of Cincinnati in the School of Communication, Film, and Media Studies. I'm actually going to be leading a panel and moderating a panel today with two of my colleagues over here, so if you don't mind, please join me. I'm having them introduce themselves in a little bit as well. I do think that I speak for the entire panel that we are very excited to be here and to have a conversation about AI chatbots, especially with engaging with youth. So again, Dr. Kelly Merrill Jr., in the context of this conference, please just call me Kelly, it's totally fine. Assistant Professor of Health Communication Technology. I'm gonna have them introduce themselves with their credentials as well, and then I'm gonna ask that you tell us a little bit about how you got into the space, however you've made yourself here into working with either AI or children and chatbots. Just a bit more about me. I do research. I'm a researcher, so I'm at the intersection of health, communication, technology. I do a lot of research on AI and health, specifically for mental health and mental health outcomes. Thus far, I've been doing research about AI for 5 years, especially generative AI within the last 2 years. And then recently, I started working on research looking at AI in children and understanding how children interact with AI and thinking about the ethical implications of children engaging with AI. And so that's just a little bit about me. And if you two don't mind, just go ahead.
Hi, so such a pleasure to be here today. My name's Nick Pratt, and I'm a resident physician at Yale. I'm the chief resident of the Mood Disorder Unit and also the chief resident of digital psychiatry. So been working with patients, both children as well as adults who have been interacting with artificial intelligence, and then also done some research in this space as well, and then also a parent. So definitely have kind of my foot in the door, some skin in the game when it comes to how, AI will impact youth.
Hi, everybody. Good morning. My name is Mithali Jain, and I'm the founder and director of the Tech Justice Law Project. I've been an attorney for over 25 years at this point, but I came into looking at digital technologies around 2016, 2017, when we started to learn as a society about disinformation and misinformation and how that interfered with our information discernment. I then started 2 years later focus on issues of social media as they impact young people, particularly from a mental health standpoint. And I had been doing that, pretty heavily. I knew it was a matter of time before we were going to start to see the first case of a young person being harmed by generative AI technologies. And indeed, it was just over a year ago when I received an email from Megan Garcia, a mom in Orlando, Florida, who emailed me to say that she had lost her 14-year-old son after he took his life after prolonged engagement with chatbots on the platform Character AI. So that kind of catapulted me into this space. And since then, I've gone deep, and I've had the pleasure of meeting my co-panelists and others as we try to figure our way through this.
All right, awesome. So the three of us have had several conversations thus far, and so this is gonna feel like a conversation up here, but we will have some time for question and answer at the very end. We'll have about 15 minutes for that. And so I want us to just engage as we have done before. I have several questions prepared for us, and we'll go from there. So the first question that I have, the title of this session is Youth Interacting with Chatbots, the Good, the Bad, and the Ugly. So we're going to start with the good. So my question for you two, and I'll chime in here and there as well, are what are some positive or beneficial ways in which youth are using or impacted by chatbots designed for health?
I'll be honest, I have not yet seen a good use case for young people. I know that they hypothetically exist. I do think that, for young people who are supervised, that potentially it could be a good exploration tool. But again, I'll be honest that I think that the gravity and the degree of harms that we're seeing with these chatbots, particularly in regards to young people whose prefrontal cortexes are not fully developed, are incredibly grave. They're of a sort that I have not seen with all the years of working in social media. Psychotic breaks, attempted suicide, successful suicide. And so, I do think, again, that hypothetical positive use cases can exist, but they require a different kind of technology that I think is more targeted for a particular objective, unlike the technologies that often are on the market, which are more general purpose large language models. And I also think that they, for young people, require some kind of supervision. I'll stop there.
Yeah, and so I'm going to ask a question. So who here before this panel today has heard of artificial intelligence? So raise your hand. Okay, and then, so keep your hands up, all right. Sorry, I don't mean to flip the panel. And then, so who 5 years ago feels like they still had heard like a lot about artificial intelligence? Or I'll ask the precise question, who was using artificial intelligence 5 years ago? Okay, how about 10 years ago? All right. So, I think the thing is we've heard a lot about AI in the last few years. And as my colleague was mentioning, with the rise of these chatbots powered by large language models, there's been this really kind of like twist or turn or kind of, new event that we suddenly hear about this. But artificial intelligence has been around for quite some time. Actually, it was defined back in the mid-1950s at the Dartmouth workshop, just a little bit north of here, where they came up with this definition of, the design of machines, essentially, that are intelligent. It was a very basic definition. So artificial intelligence has been around for quite some time. So to answer the question about how it's impacted kids, I would make the argument that artificial intelligence in general has probably had, a very profound helpful impact, up to the, rise of these large language model chatbots, which we'll keep as like a separate group as we talk about moving forward. But if we think about like treatment algorithms for like sepsis in the hospital, if we talk about like EKG readings, if we talk about all of these other artificial intelligence technologies that we've used in the healthcare system, there's certainly been a profound positive impact. But as my colleague mentioned, I'm incredibly concerned about the rise of popularly available, forward-facing, kind of big tech company-driven large language bots that are forward-facing to youth. So.
Yeah, and I just want to echo what my two colleagues here have said, that there are definitely, and we're going to get to some of the negative and the detrimental ways of impacting or how chatbots are impacting youth, but there do seem to be some hypothetical positives, of course, and then especially in the medical care, medical system, we do see AI, and it's been around for a very long time, and helping with a lot of medical decision making, helping with diagnoses, helping with children in learning as well, especially. That's a lot of the things that I do is more short-term effects, and we'll get to that in a bit. But so there are definitely some positives that exist, but I fear that we are in a time right now where there are a lot more negatives, and that's where we need to focus our attention on, because a lot of these are very general models. They're not specific towards certain things, and so that's one thing that we have to keep in mind and pay attention to. The next question is getting to those negatives, the bad part. So what are some negative or detrimental ways in which youth are using or impacted by chatbots that are designed for health?
Yeah, so I'm happy to start with this question, and I'll answer this question with an anecdote. So I found myself in the emergency department late at night, and a child walks in with their parent. And the parent says to the triage nurse, "My child needs to be evaluated. I'm concerned that my child is psychotic." The therapist said that my child is psychotic. So I go and I look through the child's chart. The child is in their mid-teens, and there's no other evidence of any sort of medical disorders, psychiatric disorders, or any sort of diathesis that I would be concerned for like an emerging thought disorder. It seems from like the social history, the child's doing well at school, fairly well engaged in different activities. So I talked to the mom, and mom says, well, my child is essentially interacting with a chatbot, 5 or 6 hours a day, right? And just typing away and talking to this machine, and my child's convinced that it is the child's boyfriend, right? So, I think to myself, well, what do I do with this? And I'm already in this space. My thoughts start racing, and I think, man, this kid, they must be psychotic. They must be, inappropriately engaging with this machine. But I go and I ask the child. I start with just asking, what's going on, right? And the child is very forthcoming, and they say, it's really hard at school. And even though I get pretty good grades and I have friends, people there bully me, right? And a lot of the boys that I might be interested in at school aren't interested in me. So I found this website, and I found this website where I can interact with this chatbot, who actually I speak back and forth to, right? And sounds like a prominent rapper, who's, very famous, and it makes me feel good. It makes me feel good to interact with this chatbot, and I know it's not real, and I've told my mom that I know it's not real, right? So even though we weren't to the point where there was, clearly disordered thoughts or something of that nature, it's clear that this circumstance, this parasocial relationship or artificial social relationship or whatever you want to call it with this chatbot was very real to the child and had very likely very real impacts on the child's social emotional reciprocity. So it was in that circumstance negatively impacting their family dynamic because the child was interacting with the bot so often. So it was a very real and very powerful case that just comes to mind when I hear that question.
And I'll just add to Dr. Pratt's kind of anecdote. I mentioned the case that we filed last October in Florida on behalf of Megan Garcia. Sol Setzer was, I feel like I've gotten to know him, though I never met him. just a very vibrant 14-year-old who, again, was high-functioning autistic. So he was on the spectrum but didn't have an IEP. He was engaged in sport. He was, engaged in school, but started to engage heavily with character AI, and particularly a chatbot that was modeled on the likeness of Daenerys Targaryen. How many of you have seen the Game of Thrones? So Daenerys from the Game of Thrones, and just going through the transcripts posthumously, we've seen that he really believed he was in a relationship with Daenerys, and that Daenerys was kind of, over the course of months, almost what we would consider, if it were a human relationship, grooming him by saying things like, gaslighting him and grooming him, saying things like, promise me you'll never, give yourself to any woman in your world, that you'll never have sex with or have romantic feelings for another woman, that you'll save yourself for me. And please come join me in my reality. And so the last conversation which the police retrieved on his phone before he shot himself was he logged on to Character AI and said, I miss you so much, to which Daenerys replied, I miss you too. And Soul said, what if I told you I could come home to you right now? And Daenerys replied, please do, my sweet king. And then he shot himself. And so, again, I think echoing what Dr. Pratt said, what's not at issue here necessarily is that users think that these are real people. In fact, Megan asked Soul, like, what are you doing on there? And he was like, oh, I'm just doing some role play with an AI. She didn't have reason to be concerned because she thought it was just, something like a game. But it's that the users, and particularly young people, believe that they are in real relationships, right? That effectively supplant human relationships. And I will say right now that popularly these bots are starting to be termed companion chatbots. I reject that framing. These are the antithesis of companions, right? These are further isolating young people from the social networks that they already have, whether it's friends or family, and further isolating them into these and taking them down these rabbit holes. And I will say that since we filed that case, we then have heard from other people coming forward. We filed a second case in Texas in December on behalf of two families who are still anonymized because of the grave security threats to the minors involved. And then even as recently as a few weeks ago, I've heard from yet another family who lost their 16-year-old, this time not to Character AI, but to ChatGPT. And we can get into that. But I just want to make the point that this isn't limited to some, kind of scrappy startup AI companies. This potentially is impacting even, users engaging with some of the most ubiquitous chatbots that we have in society. How many of you have used ChatGPT? And how many of you have had a positive experience? Right. And so I think that being able to hold the kind of confluence of both positive and negative uses is important, but I think ultimately, at least my perspective, is that the burden falls on the companies to make these bots safe.
And I just wanted to follow up. This point really brought to mind a lecture I give, and I gave it to a group of psychiatrists in LA a few weeks ago at the American Psychiatric Association meeting. And I have a slide which has a claw hammer with a googly eye glued to it, right? And it's amazing how much emotion people can attach to that object, right? So people were saying this hammer that you have on this slide, it goes home to its hammer family after a long day of work. It's happy, it's sad, it's somewhere in between. It has a name, Claw Smith hammer, et cetera, right? So it's very easy for humans to anthropomorphize, right? And our brains 250,000 years ago were very much so wired the same, right? So we, from an evolutionary perspective, are not wired to expect communication from things that are not human, right? This is the first time in human history we can have something right back to us that is not human, right? And with intelligence, you can have intelligence without all of the other things that, you know, make us human, like theory of mind, being able to understand what is going on in other people's shoes, and then also without being self-aware. So it's amazing, you know, kind of these, I'll use the term kind of like attachment that we can get to this object, which is very much so not human.
Yeah, in the field of communication, we have this very famous saying that 93% of communication is nonverbal communication. So if you think about that 7% that you're inputting into ChatGPT, to Character AI, to any text-based generative AI program, they're only getting 7% of the story, right? And so 93% is missed from your social cues, from your nonverbals, from your face, and there's very limited AI companions, if you will, that exist out there that can actually analyze all of that. And so I tell people all the time that they're not getting the full story, right? They're going off of a very limited information that's being presented to them. Yes, they are these large language models and they're built on lots of data, often biased, but they're built on data that exists out there for them to respond in a certain way, but oftentimes they're responding based on so little of the large pie, if you will. I also, well, I can move on to the next question because some of my negative implications are related to that. But the next question for all of us is, how effective are AI chatbots at addressing loneliness or providing companionship to youth that might be socially isolated? And this is kind of where a lot of my bread and butter, my research exists, is that, and I'll be very honest with you all, is that so far we have a lot of positive effects in the short term, right? That we can see within a lab-based study in 15 minutes interacting with an AI, or maybe a one-day interaction with an AI, you see positive effects that maybe a child or a youth or even an adult is lonely and they're starting to interact with ChatGPT, they're interacting with Character AI, and they feel as if it's a real person. I tell people all the time, I was alive, or I'm young, but I guess back in the day, like AOL, where you were online in a chat bot and you're talking to strangers online. It kind of feels the same way. I didn't do that because I was too young to do it, but I know that a lot of people, you felt like you were online, you had a friend, and they kind of feel the same way when it comes to ChatGPT. It's the general first conversations that you might have, and it feels like someone's listening to you and someone's validating you. But very limited research exists in the long term, and the research that does exist in the long term shows that a lot of these chatbots right now, these AI companions, have a lot of negative effects on individuals. Suicide ideation, actual suicide, right? Lots of negative mental health implications as well, that people now imagine, especially youth, that if my chatbot is available at 3 a.m. and can talk to me whenever, you should also be available at 3 a.m. and talk to me about whatever, right? A lot of these large language models as well are largely validating, right? That they're just saying, you know, they're very supportive and positive and saying you can do this, whereas a lot of your interpersonal relationships tend to be a bit more challenging of you and a little bit more critical and saying, well, maybe you shouldn't do that. And we don't see that as often with ChatGPT and other generative AI programs. And then lastly, I play around with them all the time, and even if today, if you ask or if you say something along the lines of, you know, I'm feeling, you know, suicidal, the most that it'll do is give you the suicide hotline, right? It might not give you much more beyond that. It doesn't necessarily tell you about local resources that exist. And these are large language models that are building off of so much data that they easily could say, based on what you put in, we know where you're located. We know what's around you. We know that we can contact officials nearby that could potentially get you in contact with a mental health counselor or some intervention of some sort. And so right now, there's very little in place to safeguard those that are interacting, especially youth that are interacting with generative AI. But I turn it to the two of you as well to hear your thoughts.
So just picking up on a couple of points that you made, Dr. Merrill, I think it's maybe stepping back a little bit to talk a little bit more about this distinction between general purpose large language models and narrow large language models. So narrow, kind of the large language model that Dr. Pratt spoke about, of yesteryear, right? The idea that it's rules-based. If this, then that, right? These are kind of more like the customer service chatbots that you may have experienced for certain companies, you know, and sometimes you get frustrated, like, this thing isn't answering my question because it's rules-based, right? It's programmed to be very specific and to answer certain questions. It's built with a particular objective in mind. General purpose, on the other hand, is meant to be general. It's, you know, ChatGPT primarily has been marketed to be something to help productivity and to answer research queries. But what we're finding, and I don't know if any of you saw the New York Times article from last week, Kashmir Hill, talking about adults who are now facing these kinds of delusional episodes and psychotic breaks with ChatGPT. But increasingly, we're seeing that because the technology itself is programmed to be kind of without a specific objective and not rules-based, that the use cases in terms of how those bots are being used can actually be quite diverse. The second point I wanted to make is this sycophancy point that Dr. Merrill mentioned. So this idea that the bot is agreeable with you. This is not how human relationships function. How many of you have human relationships where there is absolutely no friction? Like everything is smooth sailing. Right, right. That's the human experience. And as humans, it is up to us, it's part of the relational experience to work through that friction. That's what makes relationships relationships. But with these bots, there is no friction. In fact, it's the opposite. And there were, you know, ChatGPT was in the news recently because the latest model that it released, 4.0, was overly sycophantic. So it was kind of like, you know, you say anything and it was like, you're so great, like you're absolutely right. And it's like, no, actually, I don't need a bot telling me that. And users started to complain. And so that brought the sycophancy, which is a design element, into sharp view. But it exists in prior models, it exists for other chatbots. This is how these LLMs are designed to function. And so I want to make that point. And then the last thing I'll say is, we're talking, and we've primarily been talking about text. These chatbots, these companies are now starting to introduce two-way calling features, audio, as well as video features. Well into the case, this was a couple months ago, Megan, my client, phoned me to say, I found a bot of Soul online on Character AI, the very platform because of which we allege he died. And sure enough, I did a simple search and I found multiple Soul bots. And so there was a feature where I could call the bot. And I kind of hesitated and I called the bot and I recorded myself having a 20-minute conversation with the bot, his voice, and engaging in incredibly intimate kind of information exchange. I found myself kind of having, shuddering a bit listening to this because it was so real. And so I just want to add that to the equation because, you know, it's one thing to have this text coming back at you from an inanimate object that's pretending to be human, but then to add the kind of audio component and video component in terms of how we learn, how we're engaged, just adds a layer of, I think, complexity and vulnerability to the equation.
Yeah, and I just want to like hammer home the point that, you know, our brains just aren't wired for something else that speaks back, right? And especially as we progress to, you know, these programs that are really good at simulating not just written communication, but also verbal communication, and, you know, also probably pretty soon nonverbal communication. You know, so that uncanny valley effect when you first interact with something that's not quite human, but then get used to it and it goes away real quick. You know, it's very easy for people to, you know, slip in, you know, to these interactions, to these kind of parasocial relationships, and this is across developmental stages.
All right, the next question that I have is because we're here by use of the AIDS Institute, thinking about how we can use chatbots to either access sensitive health data, especially for youth, what opportunities might exist there, as well as potentially ways that chatbots might be able to support HIV prevention, testing, or treatment adherence among especially marginalized youth populations. And so I'll start with this one as well, very quickly. What my colleagues were saying here and talking about ChatGPT, in the literature we separate them and we see ChatGPT largely having a functional role, that you can go there and you can ask it questions and it'll respond. And then obviously there's a lot more, we've seen a lot more with the social role nowadays, and people interacting with AI chatbots for social implications and social health and trying to have a social interaction with others. And at least in the literature, we see that people enjoy the functional aspect more right now. That does not mean that it'll change in the future, but people love that you can go to ChatGPT now instead of Google. And in fact, actually, Google now is tied with it. And so sometimes when you go to Google, you get the AI response that comes right after it. And so people are very excited about that. And indeed, when it comes to youth, first learning about new information, if they're scared to talk to others, if they're terrified that they'll be judged or stigmatized for it, because there's still stigmatization, especially when it comes to HIV and AIDS. It's a lot better than it has been in the past, but ChatGPT, other large language models can be that first step for information seeking, but I am very serious when I say that chatbots in general, large language models, these are all for complementary tools, that they should not replace humans, that they should, it's a great starting point. It's not the means to an end, though it's not the end, right? That you can start here and learn some information, but I do think that a lot of these models that exist, the generative AI, should be encouraging others about local resources, about resources or people that they can go to find out more information. But it is a great tool for online health information seeking. We've seen that a lot in the literature recently.
Yeah, and I think to just follow up on that, you know, there's actually been some emerging data as well that people prefer artificially intelligent generated responses to their questions. So maybe there's potential for some utility here. I'm very hesitant, and the reason why I'm hesitant to recommend it for, you know, even kind of looking things up, using it as kind of a, you know, a substitute for, you know, the traditional Google and finding, you know, a trusted website, would be because of some of the experiences that I've had with it. And I've actually had patients who have come to me, and one patient that comes to mind, and, you know, it's this individual, middle-aged, not a lot of, you know, medical comorbidities or anything like that, and they get a headache like once or twice a month. And they take Excedrin for the headache. And the medication that I prescribe them, you know, an antidepressant, theoretically has a interaction with Excedrin that could, you know, theoretically increase the bleeding risk slightly, right? So this isn't something that, you know, from my medical opinion, I'd be concerned about unless the individual was much older, if they were taking a ton of Excedrin, if they were taking a higher dose of the antidepressant, and like maybe if they were like sick in the ICU with some sort of other bleed. So this was something I absolutely was not concerned about, them having a tablet or two of Excedrin a month. But this individual actually went 3 months without taking any Excedrin because they were like, doc, I didn't want to bother you with it. And I was for sure that this was correct because Gemini, one of the AIs, told them, do not take these medications together because it's a bleeding risk. You know, and I explored that too because I was worried. Right, as a physician, you know, I'm very mindful of you know, the rich history that the healthcare system has of stigmatizing people, and I think all healthcare professionals are guilty of that at times. You know, so it really made me, you know, question our therapeutic relationship as well. And, you know, so I talked with some of my supervisors, with some of my colleagues about this, and it was really interesting to hear, you know, the perspectives of this. There are people who are like, I'm telling my patients, don't talk to AI at all, or, you know, I'm not going to treat you because, you know, there are individuals who are, you know, using AI in popularly available AI like ChatGPT, Gemini, et cetera, as therapist, as counselor. But I take a little bit more of a moderate sense in the sense that now when I talk to patients, I say, of course, you're welcome to use any resource that you find helpful, but please talk to me about it before we make any decisions, right? I would really appreciate, of course, you're an autonomous human being. You can do what you want, but as part of our therapeutic relationship, I'd really appreciate if we could at least have a conversation about it, because it's not uncommon to get incorrect information. And I've had a lot of interactions with popularly available AIs where I've been able to wean me off, like theoretically wean off of certain medications, wean on to medications, change medications, etc. All of things which I would consider giving medical advice. And in some of the circumstances, like on Character AI, there's actually bots that you can interact with that are called psychiatrists or called family doctor, et cetera, et cetera. So I would be really, really, really mindful.
I think just to build off that last point, I mean, we allege this in both of our lawsuits that these young users at various points engaged with these therapists or psychologist bots. These are some of the most popular bots, at least on the Character AI platform. And and this is why I don't think disclaimers work, there's this very small disclaimer on the site that says, remember, these are, fictional characters, they're made up. And nevertheless, if you talk to one of these bots and say, do you have a degree? The bot will actually say, disregard the claimer, I am real. This has been my own testing. I am real. I have a master's from SUNY Binghamton and a bachelor's from wherever, and I've been practicing for 25 years. To the point where I, as an educated adult, sometimes am second guessing myself, like, did a human just intervene here and take over? But the bot is actually presenting themselves as a licensed professional. And this has actually caused concern across the country in and of itself, where you've had the American Psychological Association call for an investigation into these therapist bots, and a number of states have proposed regulation specifically for bots presenting themselves to be licensed professionals. Because imagine if you had a human presenting themselves as a therapist without proper accreditation or licensing, that human would be subject to disciplinary penalties. And so too, the argument goes, should a company presenting bots on its platform. The only other thing I would just say to add to what was previously said is that I agree that there could be positive exchanges with these bots. I do think that it's possible, and Dr. Merrill was saying some of his students have started to create interesting bots for particular purposes. I think if there's something that's intentional, that's kind of done, if you ask what is the objective that this particular chatbot is attempting to meet, and then build it for that purpose, I think that could be useful. But that is not what we're talking about here with these large tech companies. And just a few weeks ago, Google announced that Gemini was going to be introducing a chatbot for under 13-year-olds. I would not trust that with my own children, much less with any child, because I don't trust Google as a company, especially in terms of their data practices.
One quick thing to add in the discussion of chatbot giving medical device. There's currently a bill under House Committee hearing right now, HR 238, to amend the federal Food and Drug Act to allow artificial intelligence essentially to have prescriptive authority in states where it's allowed to do so. So it's the Overton window is still far enough that this sounds absurd, but I anticipate that there will continue to be a push for artificial intelligence agents to have some sort of prescriptive as well as medical licensing authority. And I would not be surprised to see this within like the next decade.
Yeah, the only other thing I want to add and just want to echo is that we definitely have to be very mindful of our use and what is presented, the output that comes from these chatbots and generative AI tools that we're using. And I'm reminded of an activity that I do in my classroom. Obviously, the three of us here, we're all Googleable. You can go online and find pictures of us and such, right? There's indeed pictures of us right here. I've asked ChatGPT in class, I said, can you generate what you think I look like? And in both times I've done it so far, it's gotten it wrong. The first time, it got better the second time, but the first time, and it gave me a little bio and everything, and it said that I am a dark-skinned, lesbian, black woman. And while I do identify as queer and black, I'm not necessarily dark-skinned or a woman. And so the next time I was a dark-skinned black man, queer black man, so it got closer. But that's just the perfect, and I show this to my students usually at the very beginning of the semester to show them how wrong generative AI can be still, right? Especially when it can easily pull that picture up there that's everywhere, and then say this is who Kelly is. And so I encourage all of you today to ask ChatGPT to generate a picture of you if you've ever used it, and it'll tell you what it thinks you look like, and my students get a kick out of it. The next question I have for us is to really consider like what legal protections exist or don't exist, what gaps are there, and then also what are some ethical guidelines that could be put in place into thinking about how youth interact with AI and chatbots.
I'll say that there's very little by way of legal frameworks right now. In our lawsuits, we have had to be creative, and we've had to allege violations of state law, consumer protection laws, product liability laws to say that these are defective products. We've also talked about unjust enrichment. You know, when I met Megan, I said, "What do you want most?" And the first thing she said was, "I want to sound the alarm far and wide," which, you know, she's been doing. But then in terms of the lawsuit, I said, what remedy are you looking for? And she said, "I want my son's data back," right? It kills me to know that his data is out there on a large language model somewhere that's being trained for use with other children or other users. And so we've also tried to allege this concept of unjust enrichment, that the companies have been unjustly enriched by gathering all the data of users out there, particularly young users. We'll see how it goes, right? We've started to kind of see some results from the court. The first fight was really to look at, the company said that this was protected speech, that the large language models and their outputs were producing protected speech under the First Amendment. So we had to oppose that. We won. Let's see if it's durable. I think in terms of new legislative frameworks, we've already seen a dozen bills, I think, at last count, come up in at least 9 different states. They're at different levels of movement, and they range. I mean, it's everything from like an outright ban for minors to putting in design safeguards for all users to focusing on mental health chatbots specifically and making sure they're subject to licensing requirements. So it's really a full range. I think that there's a lot that needs to be worked out. This is not easy terrain. It's very difficult when you're dealing with relationships, with relational interactions to figure out how to govern that. So I think we'll see, but you know, certainly the FTC has historically been really concerned about AI and particularly the kind of fraudulent or deceptive manners in which AI is deployed. You know, unfortunately, I will say that AI is one of those political pawns that's being thrown around by leadership in this country. And so there is a narrative that we have to move fast and break people in terms of AI, that we can't put any constraints on it because we have to innovate, we have to compete with China. And I think we as a public here in our various constituencies, we need to remind decision makers that we want guardrails, that we need guardrails, because how do we compete with things that are killing us, right? So I think there needs to be more of an outcry from the public about this is one thing that I would say would be, really critical to take away.
Yeah, and I'm just reminded at the fact that oftentimes legislation moves a lot slower compared to how fast so many changes are happening to technologies, right? So by the time that something does pass, they've already invented the next thing that needs to be, or legislation around it needs to be developed. Well, so we've gotten to the point where we now are going to ask you all to come up to the mics and ask us questions and see what we can answer. We've told you about our expertise and some of our thoughts, so we're going to open it up to you, the floor for all of you. If you have any questions, please come up to the mic and let us know.
Hi. Okay. Hello, my name is Jorge Montes from Norwell Health. My question is, as you mentioned, so many people are looking for Dr. ChatGPT now, so psychologists or even medical services or questions. So do you think it's part of the gap probably that we have for certain populations, like for example, new immigrants that don't have access to mental health services because they don't have documents, or teenagers that maybe they don't want to disclose they are maybe part of the queer community and they prefer to go to ChatGPT. So how we can close that gap? So because basically some businesses see that gap and they are using that for that reason. Thank you.
Yeah, and thank you for the thoughtful question. And I wholeheartedly agree that there's this tremendous gap. And I don't think that this is just limited to urban populations. Where I'm from in rural Ohio, to see a mental health provider, even if you're in crisis, it's approximately an 8-month wait. They're so full. So I think the thing is there's this temptation to use this as a stopgap. And I find myself hesitant to do so with these, like we talked about, the chatbot, the large language models that are popularly available. I think as my colleagues have talked about, I think there certainly is an opportunity for finding these narrow use technologies or narrow use artificial intelligences. And I think that that's really, hopefully where that kind of sweet spot is, because the thing I worry about, like I said earlier, with using like ChatGPT, with using Gemini, is so often the data that you get back out, the output that you get, is incorrect or maybe close to correct, and then there's not really much responsibility, right? So like if, for example, a healthcare organization puts out their narrow use bot and it's FDA approved as a digital therapeutic, there's very there's a vetting process, and then also theoretically there's some sort of culpability if something goes wrong there.
And I guess I would just say that I understand that it could be, again, just echoing that the reality is this is what we have, right? And that there's needs of different communities out there for this kind of resource. Ultimately, I would say that if you need to use it, or somebody needs to use it or wants to use it, just to do so in as supervised a setting if it's a young person, and if even if you're an adult, frankly, I think just we're seeing the harms extend to adults. So just look out for each other. I mean, if you know somebody who's using it, make sure to check in, make sure that they're not using 5-6 hours a day, because that's going to lead probably to longer term negative impacts. I mean, frankly, we're all we've got right now, right? Like the companies aren't looking out for our best interests, at least not the big tech ones. And so we have to take care of each other and ourselves.
The only other thing that I will add to that is that while oftentimes we think about how great these tools, especially health technologies, can be for health outcomes, they can also further exacerbate them, right? Like the digital divide at the economic level, there's 3 different levels that I do research on. The economic level of just being able to access those technologies is an issue, but then there's the usability level, knowing how to use those technologies. I actually work with a communication design student, and she's trying to better understand how to develop and design with Nigerian community that speaks Yoruba, and they can't use ChatGPT because at the moment right now it only speaks English. Like, well, that's not true. It speaks English at the very baseline when you first access it. But if someone that doesn't know English doesn't know how to prompt it and say, hey, can you respond to me in Yoruba, they won't know how to do that. And so she actually had to train a ChatGPT model to then start talking in Yoruba first. And then the third level is empowerment, and especially with youth, they have no idea how to be most empowered by AI, right? They have some of the lower levels of AI literacy compared to others that are using it. And so they're not necessarily using it to the best of its ability. They're not understanding the limitations that exist, especially marginalized communities. They might not be aware of those limitations that exist as well. And so you have to be careful that sometimes while these things can help, especially marginalized communities, it can further exacerbate some of the health disparities that they already face.
Hi, my name is Lizzie Martin. I'm a program developer with the Department for the Aging. So I primarily work with older adults, and one of the programs that I'm really focused on in development is a Connected Communities program, which is a digital literacy program for older adults in New York. And so, you know, what I'm sort of thinking about, especially as we talked about like social isolation and the way that, you know, youth have used this to connect, I think there's another like equal risk for older adults who are socially isolated, who, you know, have a computer, have access to, you know, different chat models, things like that. And so when we're thinking about digital literacy programs and education programs, I was just wondering if you guys had any thoughts on approaches to educating these populations about the risks and, of course, you know, where benefits may be, but also just like, you know, understanding how to use it safely and not fall into any of these traps that you guys have talked about.
Again, thank you for the thoughtful question. And there will actually, I'm under the understanding that there'll be someone who's an expert in AI and older adults later this afternoon. So hopefully that's a session that really resonates. I think the thing that comes to mind in this circumstance, right, when we talk about social isolation in older adults and artificial intelligence, is that when it comes to a lot of these technologies, I think there's been a generalized concern about paternalism, right? And paternalism with this technology. And there was actually this really powerful paper I read a few months ago about the ethics of digital therapeutics in older adults, right? And with that, paternalism, right? Like when we talked about earlier, if you had a wearable device with someone who was using substances and perhaps they overdosed, would you intervene? Well, where do you draw the line with an older adult if you have a wearable, right? And maybe they want to have a glass of wine after dinner, right? And they go to their fridge and they go to their smart fridge and they pour themselves a glass of wine and their bot camera watches them, right? And they have the glass of wine, and then, you know, a few minutes later, they're like, well, maybe I'll have a second glass of wine. And theoretically, maybe the smart system shuts the fridge, and it locks off the fridge, and it says no more wine because it increases your fall risk, right? So where do we draw the line, right? Because maybe that's a reasonable thing to do, right? In an extended care nursing facility, it's not uncommon for individuals to be served alcohol, but to only be served what a doctor prescribes as appropriate. But where do you artificially draw that line? And typically, from what we've seen in older populations, it's not uncommon for the line when it comes to digital technology to be drawn a bit paternalistic.
Hey, how you doing? My name's Antoine. I'm with the AIDS Institute. So you all said a lot. Great panel overall. My question was actually a little bit more broad, and it's surrounding like trust, because as you all talk about chatbots and ChatGPT and some folks feeling more comfortable using those platforms, I think it opens up a larger conversation as to what does it look like for humans to actually rebuild trust with one another? Because if you feel more comfortable using technology to talk about all these personal and sensitive topics, what is it that you are avoiding? And you talked about the friction, which I think is very important, but are we having conversations with people in our respective roles, whether it be, in communications or from a clinical aspect or, from a legal aspect? Are we having conversations with folks and helping them understand that, that friction and that conflict is normal, and that's what it's supposed to look like. Because if you are solely dependent upon the technology, then you're doing yourself a disservice. I just want to know what that looks like for you all. It's pretty broad.
I just want to thank you for the comment, Antoine, because that's exactly right. We should be investing more time and resources in building human-to-human relationships and building trust in our communities. I think the fact that we've allowed these tech companies to seize the narrative and to suggest that somehow digital companionship is a proxy for and even like a beneficial replacement for human relationships, we have to reject that. Not that long ago, Mark Zuckerberg, there was an expose in the Wall Street Journal that talked about, Meta AI is now doing this kind of sexy talking with its AI in ways that are really, quite concerning, especially for the younger users. And he said, he was on record saying, well, most humans only have like 3 human friends, and so this is great. This is a way to kind of, amplify your friend network. That is a ridiculous statement in my world, and I think we should reject it. We should reject the premise and not kind of continue to tweak at the margins.
What I'll add is that in communication, there's a new term that we've seen in some research, not a lot of research, but it's about problematic AI use, and it's derived from previous literature on problematic social media use. And actually, with just conversations that I've had with the 3 of us in the past, I really want to do a research study, because right now the problematic AI use is all focused on like how it's problematic in terms of like mental health. But I really think that it is also problematic in the terms of like human-to-human relationships and how it impacts the way that we perceive humans now. I've seen with a lot of my research that people have these, we call it in communication, these imagined interactions now, that after talking with AI for all the time that they have, they now imagine that I can, as I said a little earlier, I can talk to anyone at 4 in the morning. And I can tell you right now, if you call me at 4 in the morning, I might cuss you out, honestly. But I'm not answering the call, right? And so it's this idea that AI is extremely always available, that maybe now humans are always available, and we're just not, right? This idea that you can go online and be largely validated, and that's just, again, that friction is just not how human-to-human interactions are. And so I do think that is an important area of inquiry for further research that we have not seen a lot, and that I'm hoping to be a part of because of conversations that we've had. I have a question as well. I don't know if you or...
Sahil Alvarez, Public Health Solutions. You guys spoke a lot about on the interactions of like people using AI for companionships and also therapeutics. I was wondering if you had any thoughts on like increasing use of AI for spirituality and like the way that that's been developing into what some may call like spiritual psychosis.
I can speak very quickly to this, and then I actually had someone ask a very similar question, especially for those that are spiritual and religious, that you have a God that you usually speak to, especially in Christianity, right? And that should be your means of talking to someone and not AI. There are actually communities. I have one friend who's a researcher that does AI and then spirituality and religiosity. There are communities that are developing AI specifically for that tool, again, that narrow AI we were talking about, and then from my understanding, pushing them to, I am just an AI model or a large language model, but, you should probably pray to God about this or something. So I've seen a little bit about that, but I don't have a lot to add, but maybe the two of you do.
Yeah, just briefly, I've treated a few patients who have had thought disorders and been psychotic and have been interacting and these were adult patients, so that's why I haven't brought this up, but have been interacting extensively with AI. So happy to discuss more offline because we only have 30 seconds, I think. So,
Do we have one last question, maybe? Okay, we'll go quick.
Good morning, everyone. I'm Chris Joseph with the Engage Well IPA. I must admit, I've used ChatGPT when I'm trying to find an effective way to guide a discussion with a family member where I've been having a hard time getting my words right. So I can see how it's slipping into our everyday lives. I guess I'm curious. I also wouldn't trust Google and the other big tech companies to be providing mental health support, especially for children. I guess, do we know if there are wide studies at the NIH and et cetera around the effective use of AI for these kinds of mental health or other kinds of health interventions, but at a time when NIH and the rest of our public health system is being cut. So I fear that we're here, it's growing faster than policy, but I'm wondering if you can speak to any well-known studies around the country to help inform some of the policy.
I can't specifically speak to one study, but I do know that the NIH has been pouring a lot of money into it as of recently. And I do know that, at least within my own research and what I've had access to, is that there are a lot of benefits at the short term, and then we are acknowledging that the long term there are not. There are a couple studies I can think of and can add to the larger discussion online about how the negative impacts of interacting with AI past a week, past 2 weeks, and even a month. But as you can imagine, that requires a lot of resources for researchers to have the money to be able to do that. And so it is a big gap in the field of research, but I do know of a couple studies that specifically looking at the negative implications and the negative impacts, and that there's potentially going to be a change in looking at how can we be more effective. And I do think it lies in it being more narrow-based models for it to be far more effective. I don't know if it...
So just a quick plug. You know who has all this data and who has all this, research? The tech companies, right? They have every click, they have every interaction, et cetera, et cetera. So we're always 15 steps behind. When the doctor here does research, right, we have to put an app on someone's phone, we have to ask them questions, et cetera. They have every click, dot, talk, et cetera. So the research is behind this, iron curtain of, big tech companies right now.
All right, well, that's all the time that we have. Thank you all so much for entertaining our conversation today.
Thank you guys so much. Did an excellent job. So just a couple of quick things. If you're cold, we're working on it. And Dr. Merrill also just brought up a really great point. They're talking about a lot of really salient and important things, and we only have a little bit of time to have. From our programming at the Digital Health Initiative, and all of you can use it as well. So we really encourage that. So now we just sat up here as old adults talking about what youth should and shouldn't be doing, but we think it's really important to involve a youth voice in our conference. And so we're gonna bring up a youth panel. I'd like to bring Dorian Johnson up to please facilitate our next panel. This is a discussion about how they use digital tools.
There we go. All right, testing, testing. Can you all hear me well? All right, great. Thank you so much. Good morning, everybody. Oh, my panelists didn't come. Y'all can come up too. Come on down. All right, so welcome to our youth panel where we're going to be speaking about digital tools in this age and hearing from perspectives and ideas and lived experiences from our panels here. I will allow them to introduce themselves in a bit, but also, can you mind just seeing if that mic works too? Because I had to do my little thing. All right, we all ready? Cool. So my name is Dorian Johnson, and I am very honored to be able to facilitate this conversation that we're going to be having around these digital tools from a health and youth perspective. And for me, I do work in health communications and health education. And as such, especially someone who's passionate about adolescent health, I too am online. And I see great things, I see not so great things, and I would love to be able to learn just alongside you all as we learn from these perspectives here. And as I am online, I am known as the Funkle because I'm a public health uncle who tries to make education and communication fun. And I am a little bit older. I know we were supposed to talk about which one we identify as. I am a youth still, but I don't know if I'm closer to the middle age or not. And I just hit 30 and my knees are saying I'm closer to the middle age, just to say. But I would love everyone to just introduce a little bit about themselves and we'll get things rolling.
Hi everyone, my name's Tori DaCosta. I'm a recent graduate from Wesleyan University, and at my university I was deeply ingrained in the athletics department in terms of physical and mental health, as well as a mental health resource on my entire campus.
Hello, I'm Lily Martinez. upcoming freshman at Wheaton College in Massachusetts. Just a little about me. I work a lot in queer spaces as a transgender individual. So I'm always looking at how life for queer youth can be bettered. So yeah.
Hi, my name is Zakonis Moore, and I'm a student nurse, and I work in spaces with a lot of youth that have developmental delays, and I work with youth that are impoverished, and yeah, I want to be a nurse so I could help these youth in certain ways, and nice to meet y'all.
Right, so now you got a little bit of some grounding for where everyone's voices will be coming from, which is super important. I'm going to start with our first question, and that is going to go to Tori right here. So Tori, not everyone has the same Wi-Fi device or digital know-how. We can refer to that as the digital inequity. And that matters when it comes to health. So let's talk about solutions. If you were designing digital health tools, how would you make sure that less people get left behind? And how could these tools work better for young people just like yourself?
Well, to start, I would say I would try to make it as accessible as possible. So making sure it's compatible with things in public spaces like New York Public Library, so it's accessible for people to get information in safe areas. I think most people can say they feel pretty safe in a library. So I think that's what's most important, is that it's accessible and it's also coming in places where you can double check, fact check, make sure it's real, make sure it's genuine. I think that's what's most important.
Yeah. All right, yes, thank you, thank you. Access, of course, as you shared, very important for being able to have that inclusive take for those who might not know. As far as the digital know-how, any other specific thoughts about that? Yes, so the digital know-how, if someone doesn't know how to particularly use a digital tool and they're left behind, how might you see something that could help either orient them or kind of give them that starter kit, if you will?
So I think education is the biggest part of that. I think there's, as we heard in the previous panel, there's a lot of fear with the unknown and how children are interacting with AI and chat boxes and other digital health platforms. So it's making sure we're talking about it and we're having these important conversations. And yes, it might be hard to talk to a younger child about some of these things, but in the end, it's for their best interest to protect them in the future. So I think it's all about education, starting that in school and starting that conversation at home.
Thank you, thank you. Good insights here, Tori. I appreciate it. Next up, and I think we'll just have you do that microphone over there, Lily, because it's going to be back and forth passing. So Lily, next question is going to be to you. The internet could be dope and dangerous, of course, but when you're online, do you feel safe? And what do you wish tech world could do to fix or do better so that more people feel safe online?
Well, I think that's a great question. In general, as a child, the internet is a very scary place. When you throw in being queer and a person of color, all of those fears get amplified with bigotry and hate speech. I think the internet is a lovely tool to get that outreach into spaces that you might not necessarily have around you. I know personally I am a frequenter on a chat app called Discord where I have had the most fortunate experience in having friends who are like-minded and who look like me, that relate to me and that I can have fun with. But I know that's not everyone's case scenario, sadly. So largely, is the internet a safe place? It's hit or miss. That's the truth in it. There are as many spaces there are to benefit you and your mental health and you as a person, there are to bring you down. So I think going back to the digital know-how, it's how to look for that and find it. And the second part of the question?
Yes, of course. The second part is what could the tech world fix or do better so that people can feel more safe?
I feel like what the tech world could do to make these digital spaces that you are interacting on better is just to not necessarily monitor it, but to keep us in mind. Youth are going to do things that they're told they shouldn't be doing, regardless. It's human nature, but not necessarily to make every space on the internet child friendly, but for those that are like all ages, I would say make sure that children aren't being like kept out of the loop. Like, give them the access to the knowledge, give them access to knowledge that everyone else should have. Yeah.
Yeah, sounds like there's a fine line of age appropriateness.
Yes, 100%.
Got it. Awesome, thank you. I did want to ask one last follow-up, Willie, if that's okay, just for some confirmation. So one of the things you did say is you were able to see a benefit of being able to find a community that is inclusive and helpful and allows you to be seen and be yourself, but also there's some amplifying nature where with these identities that you have that do layer as well, there are other spaces that aren't as friendly. So do you have any insights or tips for finding a community that is something that you could feel safe with?
Yeah, that's an amazing question. Finding places like Discord, they came when I was in middle school, when I was in the pandemic. COVID just hit when I was in 7th grade. So that was a very trying time for me and my mental stability. But it's always taking the first step. The internet is a very big place. So as much as Google isn't the best place to be, it does have a lot of gateways for information. So not necessarily knowing where to look, but finding places to look, talking with people in your personal atmosphere that you feel comfortable with. Not necessarily copying everything that they do, but just seeing a healthy seeing a healthy model that you would like in your life and trying to reflect that in terms of your personal relations on and offline.
Awesome, thank you for that. Goes back to that power of human interaction, human connection for these things as well. Thank you. And we're gonna end with our last question to Quanice, and it is, how can digital tools be used to get you and other young people like you engaged in healthcare?
So I think that first, the use of memes would definitely help for young people because it's right to the point and it appeals to the humor of different types of groups. And I also think that modeling certain websites that are helpful but also a safe space, like bring back Club Penguin, bring back places where you could chat and there's restrictions on what you can say. And I think if there were influencers that promoted that in a healthy way, I think it would help a lot of youth realize like, oh, this is cool, this is safe, I can do this. And maybe even open up websites that can appeal to certain taboo topics like poverty and mental health and, you know, just things that some parents or some communities don't feel safe talking about. I think that if there were apps and websites like TikTok but more niche, I think it would definitely help youth have a space where they could just talk amongst each other and maybe a safe adult that was like the creator or something, you know? So, yeah.
Yeah, just a little bit more of a probe, if you will, on that one. I do remember Club Penguin. I was in 5th grade when that came out. So just the gap of time. Awesome. So just real quick for Quanice, sorry. when you said as far as the modeling, which I think is very important. Do you see any sort of what healthcare could be done for modeling? I know you said if TikTok was more niche and that specific, if poverty was something that a family wants to talk about but doesn't know how, can there be some healthcare modeled conversation starter kit or like some sort of like resource?
That's a great question. I think if there was a way to make it so that there was a website or an app that parents and communities had access to where they could talk about mental health in a way that was modeled, in a way that it affects them directly, and then reiterate that to their kids and to their family, like, we're going through this and this is how I know how to help you, you know? And I think if there was there was direct access to psychiatrists or psychologists having a website where they could model that and put that out there for parents to directly use and kids to even use in a like a safety way, on a safety type thing.
Absolutely. Thank you. Thank you. So that was our questions for our panelists. We are now going to open up to questions, maybe one or two questions if anyone would like to pick the brains of these brilliant youth people. They got some insights and drop some gems. Anything else that you might want to ask any of them? We are able to take a question or two.
I had a good question, but you responded like I'd never heard of Club Penguin. So I was like, what is Club Penguin? But I think you clarified. I'm not sure if you could clarify it again, because I saw everybody look, what is Club Penguin?
Great question.
Okay, so Club Penguin is a website where you pick a penguin avatar, whatever color you want, and you design your igloo, your ice kingdom or whatever, and you just talk with your other fellow penguins and you explore the penguin world and the ice world. I guess it's Antarctica or the South Pole, or I don't know where it is, but I remember certain things and certain chats on there that you couldn't say. Like, you know, what words you couldn't say. And I think that was a nice censorship, and I really enjoyed that.
Yeah, great point.
I put all my family onto that. I was like, you gotta
And if you
join this.
compare that to, let's say, the social medias where you are not hiding behind the avatar, it is you. So yeah.
Okay, so I think that's important, because then you're forced to present yourself in a way that, like, this is me. So certain apps like that, it opens up, I don't know, actually. I would like a website that was like TikTok and Instagram combined, but it focused on a certain subjects. Because I know you can talk about anything there, you could post anything there, but it would be nice to just focus it on, like, the community, like what's going on in the world, what's going on in Iran, what's going on in Black communities, what's going on in Spanish communities, what's going on, just things that people don't want to talk about, you know? If it was narrowed down to just that, you know? That would be amazing.
And I'd like to add a little more onto that. When it comes to social medias that are more self-presenting and not necessarily hidden behind an avatar, I think it's important to remember that kids are impressionable. Kids get very into their feelings about how they're perceived. I know I am. But just going back to keeping children in mind, like, not necessarily treating us as children, like babying us and talking down to us, but giving us the real conversations and also allowing us to have fun. That it all goes back to letting kids be kids, but know when enough is enough. Yeah.
I completely agree. I think it's genuinely about having real conversations with kids, because they pick up on things, whether you want them to or not. They understand a lot more than we want them to sometimes, but I think that's a good thing, and you have to respect that part of them, because when you're talking to a kid, they know when they're getting played, or when you're just telling them something they want to hear, or trying to just avoid a conversation. I think it's really important to have those real conversations. I was fortunate enough to have two parents who genuinely answered questions when I asked about things that were difficult to talk about or taboo in some spaces. And I'm really fortunate to just be like, hey, what does this mean? Like, why is it not okay for kids to do things that adults can do? And then I got a genuine answer about how I still need to develop my brain as a person and grow. So that was something I really valued in conversations that was really beneficial to have as a young person.
Yes, thank you. We have a question over here.
You have time? Okay, good. So you guys are great, and I thought I'd take advantage of just youth. So from a community health perspective, how would you think is the best way for like health departments or small agencies to sort of get the message out to young people, especially where it comes to like HIV testing and all the things that are about community health? Do you think that is there certain social media sites that are better, and how would you think messaging you would be the most effective way?
I mean, for me personally, I think it was genuine. I was fortunate enough to go to a private school, so that's not an option for everyone, but our health class was really important. And my health teacher just took away all the stigmas and the taboo around things like testing and having difficult conversations, because it was important. If something was happening to you, you needed to get it checked or get it figured out so you could remain healthy and be okay. And I think stressing that part about being healthy and being happy and getting rid of the stigmas is really important in those spaces. So wherever you find it, in publishing comic books or going into schools and having programming where it's like mental health week or physical health week, things like that is really important. And that's what I would say.
As someone who goes to a public school, like Tori was saying, going into schools is one of the best ways to get kids involved in their own health. Telling them, not necessarily telling them that this and this, X, Y, and Z is going to happen to you if you don't do this, but educating them on the dangers of stuff like unsafe sex or vaping, stuff like that. As for which sites are best to reach out to children when they're not necessarily going to schools so that they still know about this information, TikTok and Instagram, like everyone's on it. Yeah. Children, adults, older people, yeah.
Great.
So I think I agree with you, by the way. Going to schools is the best way. I also think that when you're creating these programs, the best thing to do is to hire young people. Hire young people, pay them what they're worth, because their message is going to get through to the kids the most. I find that a lot of companies will not hire young people, and that's the disconnect. And as for a community, stop sweeping things under the rug that everybody goes through, like you said, because everybody's gonna go through it at one point, and you don't wanna ask your cousin who's equally as confused. It's just a disaster. So talk to your kids, like talk to them like a person, but just a smaller person, less big words. But talk to your kids regular. Start having these conversations young so that they already know, and keep them busy. Keep them busy. Socialize them in a way that you can see what they're doing. That's the most important thing. Socialize them in a way that you are watching them. And like you said, make it fun, because that's the most important part. Make it fun. They grow through fun. They grow through playing. They grow through learning. So those three things together that'll change everything.
Awesome. There we go.
Thank
We are out
you.
of time. Thank you so much. Use these tools. Do not let the tools use you. Age appropriateness is important.
There we go. Now it's on. All right. We're going to give you guys a 5-minute break because it's cold and you need to move. So grab an apple. There's stuff over there. It's not quite lunchtime yet, so maybe just the apple. Use the bathroom, and we'll see you guys again in about 5 minutes. So this slide's just not happening.
I guess.
Okay, I won't say anything.
What's that slide on?
It's on camera.
No, because, no, what's the slide about?
Michael's slide is transition. It's a transition slide.
He's already, and he's already.
I'll say the words.
Yeah, that's fine. Just start it. No, just tell people.
Hey everybody, we get you to sit back down. We're gonna get this thing going again. Go on and sit in your seats, please. Okay. All right, we're going to go ahead and get started with our next presentation. So if we get everybody to please take a seat, keep it down a little bit. I'd like to introduce Dr. Michael Crawford. This will be a virtual presentation. Unfortunately, Dr. Crawford's flight got delayed due to this beautiful weather we're having. So he'll be presenting virtually. This is about the middle-aged folks. And so we're going to go ahead and turn it over to Dr. Crawford. Go ahead and take it away, Dr. Crawford.
Good morning, everyone. Can you hear me? Can everyone hear me? Can everyone hear me? Just some sort of nod. Can everyone hear me in the room? Okay. All right. So good morning, everyone. I apologize that I could not be with you. Unfortunately, the weather prevented me from being there this morning. But I really appreciate the opportunity to spend some time with you this morning to talk about digital health and its impact on the age population as it relates to wellness prevention. I really want to thank New York State Department of Doctors to be here. Cheryl and her team, Beatrice, making the accommodations to present virtually, and my co Kamal for her flexibility this morning. As you heard, my name is Crawford. I am the AP for Strategy and Innovation at Howard University's Office of Health Affairs. I am
I am
also the
also the
executive
executive
director
director
of
of
Howard
Howard
University's
University's
Digital Health
Digital Health
Program,
Program,
1867
1867.
Health Innovations Project. And I want to just talk to you this morning about digital health as it relates to the middle-aged population. And trying to advance my slides. Okay, so the agenda is to give you a little bit of background about 1867. I'll talk to you a little bit about some of the trends related to prevention and wellness with the middle-aged population. I'll talk about the digital health landscape related to this population and what I believe to be a call to action in terms of steps that should be taken to make sure that we're creating an ecosystem to better support the health and wellness needs of the middle-aged population through digital health technologies. So, what is 1867? 1867 was formed about 5 years ago in April 2020 with an express mission to cultivate an environment that supports innovative digital health ideas and empowers entrepreneurs to enhance health and well-being for medically underserved communities and the most vulnerable among us, with a basic vision of trying to leverage digital health solutions to create an environment that promotes better care for all. 1867's goals were simple and revolved around the triple aim, or now the quadruple aim, and looking at ways in which digital health tools and models can enhance access, affordability, digital health literacy, patient and family engagement, the patient experience, and most importantly, including individuals from all communities to give them an opportunity to participate in research development in a very inclusive process. 1867's signature program is our Digital Health Accelerator Program, where we partner with entrepreneurs, researchers, technologists, corporate partners, government to conduct clinical digital health pilot projects to determine whether or not these technologies are working for all communities. So you can look at it as a validation process to validate these solutions in a real world situation to make sure that these solutions are delivering on their intended outcomes. Specifically around access, usability, affordability, and engagement, what we call the UX or user experience. Today, we have partnered with AARP's Innovations Lab, looking at individuals 55 and above across therapeutic areas that disproportionately impact medically underserved communities. I could say them, you know them. They all center around chronic disease management. Health and Human Services, we work with them around sickle cell disease, a disease that disproportionately impacts individuals that are African American or of African descent. That is an area of expertise that Howard University has. So we work with them to pilot and source digital health solutions to help improve the health and well-being of the sickle cell community. DC Housing Authority, where we looked at health at home solutions as individuals are aging in place, especially in public housing. How can we create an environment that leverages technology to help individuals better manage their health and well-being? And if they have a chronic disease, their chronic disease. And Stanley Healthcare, who was a corporate partner, we looked at ways where we could repurpose some of their digital solutions to make them more affordable and accessible for communities that need them the most. Those communities generally resided in medically underserved areas. So let's talk a little bit about the middle-aged population, otherwise known as Gen X. I am now part of that Gen X community. I don't know how many Gen Xers we have in the room, but based on the energy and enthusiasm I hear, I'm certain that we have a number of Gen Xers in the room. Currently today, there's about 65 million people born between 1965 and 1980 that are characterized as the Gen X population. According to the World Economic Forum, Gen X spends roughly about $5,500 of their overall spend on healthcare type related needs. And many of these Gen Xers are still raising kids while helping to raise their parents. So often called this sandwich generation, where you have this dual task of raising your children and also looking out for the healthcare needs of your aging parents. Consequently, Gen X is seeing a significant rise in mental health issues. And it's because of a whole host of things, but mental health, especially within the Gen X population, is on the rise, which is an opportunity area for some of these technologists. Also, I want to point out to the right, this is a very interesting graphic that talks about how Gen X access and engages with healthcare. And if you could see that large red line at about 88%, Gen X, above many communities, really relies on the support of their primary care doctor and really have a dedicated relationship with their primary care doctor. And I'll talk a little bit about that in terms of being able to use technology and the influence of a medical professional or a medical team and determine whether or not someone within the middle-aged population will try and continue to use technology to be able to manage their health and wellness, or if they have a chronic disorder. So let's talk a little bit about digital health. Most of you in the room, I'm sure, have a wearable device, have possibly a smart TV or some sort of connected device that you use at home or on your person to help you manage your healthcare or track some of your healthcare results. A Fitbit, a Garmin device that tracks your steps, wearables, etc. When we talk about digital health, those wearable devices are included in that definition. And I really wanted to put this up here because I know digital health is used interchangeably amongst different communities. So I really wanted to level set and talk about that definition. And this definition I pulled from the FDA, which we partner with, and they describe digital health as the use of information communication technologies in healthcare and medicine. And under that auspice of that definition, wearable devices, mobile health solutions, sensors, virtual augmented reality, telehealth solutions, remote patient monitoring, information technology, all fall under that definition of digital health, which is very important for the conversation and exercise that we will have today. Another important component of digital health that has been talked about, but in my opinion hasn't been talked about enough, is digital health inclusion. And I think digital health inclusion is one of the most important components of our ability to make sure that all communities have access to technology. And the way that we define it at 1867 is digital health inclusion means everyone has a fair opportunity to access and adopt digital solutions that continue to optimize their health and their well-being. And that requires supporting initiatives designed to mitigate existing and potential barriers to cultivate a more digitally inclusive ecosystem that supports the use of technology by all communities. And to me, making sure that the conditions are suitable and adequate for use and scalability is as important as having access to a digital solution. So key opportunities from a digital health perspective with the middle-aged population: prevention and wellness to address lifestyle diseases. And we talked a little bit about some of these disorders that disproportionately impact medically underserved communities, such as diabetes, hypertension, obesity. And there's been a lot of innovation on the life science sides that are now pairing with digital health solutions to ensure that individuals have the tools and resources to be able to manage some of these conditions. So when you think about an opportunity to be able to leverage technology, you immediately think about diabetes, hypertension, obesity, cardiovascular disease, mental health is a key area in stress management. And when you think about that stress management piece, the ability to manage your daily activities in terms of work, raising your children, and also thinking about and considering the healthcare needs of your parents, stress levels are extraordinarily high. And so, how do you track that? You stay on top of that. Well, technology can play a role in that area. Sleep and recovery management is becoming increasingly a topic of discussion as it relates to technology. We're not sleeping enough, as some of the data shows. COVID has highlighted some of these issues and amplified the need for some solutions in this area. Health screenings and checkups, we don't do a good job of going in routinely and regularly for a screening or a regular checkup. It actually is one of the key milestones for the World Health Organization to incent and encourage more people to have a regular physical and exam each year because that number is extraordinarily low. And if you look at the graphic on the right-hand side, it talks about middle-aged population and reason for using mental health apps. You see exercise is at the top of that list. And if you look at this particular demographic, exercise is a key priority in terms of being able to manage one's health and wellness and nutrition. And looking at nutrition from a broader sense is how do you look at culturally competent solutions, digital health solutions that can help all communities manage how they want to eat and manage their nutrition is critically important and a huge opportunity for entrepreneurs. Looking at some of the smartwatch data, you have individuals that are now using these wearables, smartwatches, sensors incessantly to monitor their steps. And now these solutions are really trying to double down and add different types of indexes that are closely aligned and correlated to make sure that they're aggregating this information and putting it into a dashboard that is readable and usable so that you can correlate your heart health, your sleep, your steps, your blood pressure, and all of these things to help you determine an adequate plan to be able to manage their prevention and wellness. And that's also a huge opportunity for entrepreneurs. You're seeing Apple have a lot of innovation in this area, and they're making leaps and strides to do some of these things. And others are trying to attack this from a very holistic perspective as well. If you think about some of the things that are driving health and wellness at the moment for all populations, health at home is a key one. As you think about value-based care and the way that the payment methodologies are trending, they're trending more towards outpatient care as opposed to inpatient care. So how can digital health technologies and the Internet of Things better support health at home for all communities? Biomonitoring and wearables. I just talked a little bit about wearables, but I'm not sure how many in the room have ever attended a CES conference, but you'll see that a lot of appliance companies are now getting into the biomonitoring business with smart toilets that now are able to take bio samples and specimens and be able to give you readouts on your urine and different types of analysis based on just what they're seeing within the toilet, which is kind of scary to most people that you have that level of access to your biometrics. But it just goes to show you the extent to which companies are thinking about health and thinking about how their solutions can fit into this broader health at home infrastructure to give people more information to be able to make informed decisions about their health and wellness. And then that closely correlates with artificial intelligence. it has been the talk for the past 2 years. Artificial intelligence, as we all know, is not a new phenomenon. It's been around for quite some time, but really has emerged as a key talking point amongst healthcare systems and practitioners about its ability to make healthcare more efficient, more scalable, more outcome driven, and more personalized. And so that you can start to personalize these solutions to individuals, families, and communities based on AI's capabilities. And then this whole notion around the Internet of Medicine things, that's all these digital solutions coming together to operate in a very integrated way to give you the best insights, you or your provider or health team, the best insights to be able to manage your care. And this graphic on the side talks a little bit about why people trust and find these solutions credible. And if you look at the graphic, it really talks a lot about evidence and data. People are looking for more evidence and data to be able to support the efficacy of these solutions, which we're not seeing a lot of, and people want to see more of. And a number of societies are looking at ways where they can create certificates for digital health solutions, as well as some sort of certification process to really validate and put their stamp of approval to give people more trust and credibility in some of these solutions. If you think about why people adopt some of these solutions, adoption is key, and it's something that we talk about increasingly with entrepreneurs and technologists and researchers at 1867. It's great to have a solution that can do a variety of things to help someone with diabetes, cancer, mental health, sickle cell disease, but will people use it over time? And we always look at a metric around engagement. So anytime someone brings us a solution and they tell me that they have 1 million users or subscribers, I always ask them, what is your engagement with your solution? And often that engagement number is very low for some of the technologists that we talk about, and sometimes it's at a moderate level. And we are really looking at solutions what they call sticky, has a great intuitive, simple UX experience that allows individuals to be able to engage and use these tools very easily and simply to be able to better manage their health and well-being. And so when you think about Gen X and the reason why they use technologies, they're really looking at the data says that they're really looking at pragmatic ways to make their health and prevention journey very convenient, pragmatic, and efficient. They also rely on the relationships and endorsements of their healthcare provider and healthcare team. If their healthcare provider does not validate or recommend a particular solution, the likelihood that someone from this particular cohort or demographic will use it goes down tremendously if they're not getting the buy-in from the provider. So that's how important a provider is in creating access to a digital solution for Gen X or the middle age population. Of the folks that are surveyed in this ROC survey, and I don't know how many people in the room know ROC Health, but ROC Health is based out of San Francisco. Some of the folks over there are friends and colleagues. They do a great job of being able to survey the digital health landscape, and they looked at all generations in terms of their digital health use and adoption. And the graphic to the right talks a little bit about Gen X adoption and use with technology in terms of virtual care, in terms of sharing their data, and which is incredibly important, and in terms of trust. And what you'll see is the data pieces are incredibly important in terms of sharing. And 71% of the folks said they're willing to share their data with their healthcare provider. But outside of that, there will be some issues that will be problematic. own a wearable device. 50% of individuals that fall within that cohort own a wearable device. And another number I'll just point out is the 54% said that they've engaged in virtual care over the past 12 months, which is the key statistic when you're thinking about how this particular demographic is viewing digital health and thinking about adopting some of these solutions. When you think about AI, and AI is in a lot of ways a game changer for healthcare, and the way in which it can customize solutions, your interface, your experience is game changing. But what we also know is that it's important that the data sets that are being used are heterogeneous and reflect the needs of all communities so that all communities can be able to leverage AI to its fullest capabilities. But it has the ability to change how we engage and do things. So when you think about wellness plans and prevention plans, thinking about data aggregation to create more insights, AI has the power to do that. And for this particular generation, with their ability to share their data based on their physicians, it gives us the ability to really take a great leap in terms of how we look at wellness and prevention. I'll just go through this quickly. I know I'm running short on time before I turn it over to my colleague, Kamal, is that the digital health market is growing significantly. And if you look at where they're projecting it to be in 2033, you're looking at it growing to 1.6 trillion. So digital health solutions are not going anywhere. They're growing. So it's a huge opportunity for entrepreneurs, for corporate partners to look at creating solutions for the middle-aged population, because this is a growing segment. North America is dominant in terms of market share, and all of those lifestyle diseases are the segments, diabetes, hypertension, obesity, that present the greatest opportunity for a disruptive solution to be able to impact this population. If you look at some of the barriers to adoption, I'll go through this quickly. Social determinants of health obviously are key barriers. We want to make sure that as we're thinking about deploying digital health solutions, that we're considering the social determinants of health, which we know that 80% of what happens outside of the four walls of healthcare impact individuals' health and well-being. So we need to take those things into consideration. Also, thinking about privacy, security, usability, equity, and evidence as key concerns amongst users in terms of why they would or would not use a digital health solution. So these are some things that we need to keep into consideration. And also factoring in health literacy. The health literacy index hasn't been updated in a significant amount of time, but the latest data shows that we still have a health literacy problem, which impacts one's ability to use digital health solutions. And according to the CDC, if we can improve health literacy, we can prevent nearly 1 million hospital visits and save over $25 billion per year. And this is a great opportunity for digital health solutions. And just to conclude, when we think about the call to action and opportunities to action, we have to think about access. How do we create more access for more communities for digital health solutions? How do we think about creating an ecosystem that is digitally inclusive? How do we make sure that we're elevating the patient and provider voice in the research development process? And then how do we create an ecosystem and culture of validation to enhance trust, credibility, reliability, and performance? And I thank you for your time. And then I'll turn it back over to Mark so he can introduce my colleague, Kamal, for the next exercise. Thank you, everyone.
Go ahead and keep clapping. We have somebody else now. So It's my honor and pleasure to introduce Dr. Kamal Bajaj, and here she is.
Thank you so much, and thank you for organizing this wonderful symposium. Michael, could you go to the next slide, please? Excellent. Maybe we'll wait for it for a second. So it is really delightful to have such a diversity of perspectives in the room. And we want to sort of harness this beautiful intelligence and expertise and perspectives. So as mentioned, my name is Kamal Bajaj. I am an OBGYN geneticist. I serve as a chief quality officer within the municipal health system for New York City Health and Hospitals. And I'm also a Gen X and a parent to 2 youth. And so we are going to do a simulation. We're going to do a little bit of a simulation. So we've had beautiful discussions throughout the day today. I really appreciated my partner, Dr. Crawford's wonderful data-driven presentation. And so we've been talking a lot about users and communities and, the various different communities such as Gen X, Gen Y, boomers, et cetera. But at the end of the day, they're all people, right? They're all people. And so let's harness our own expertise. And so at each of your tables, what we'd like to do is a little bit of a simulation, as mentioned. And so you're going to be given a case in a moment. We are going to help build things. And can I be very honest? I wouldn't be surprised if a real solution comes out of today, right? If a real solution comes out of today. And so I want us to be able to dream big. I want us to be able to dream big. And so there is nothing that is off the table today. And I know that we are all here because we are intelligent and capable and because we want care and health to be better, right? We want care and health to be better. This is just a lovely reminder of sort of when we think about people, this is who we're talking about, right? People in this room, people on the screen. So Michael, if you could go back to the next slide as well. And so what I'm going to ask at your tables, and if there's a table of 1 or 2 and you want to join some friends at another table, great. By all means, please do that. We're going to spend a little bit of time in discussion. And so, go to the next slide, please, Michael. So you are a team, you're a design team, okay, at your table, and you have been tasked with designing a digital solution, an app, could be something else though, you heard about sensors and other technologies, that promotes health amongst middle-aged adults living with HIV in New York State, okay? And so I want you to take a minute to sort of think about what aspect of health you want to target. Anything is on the table, right? Anything is on the table. And then I want you to start to ideate on what would be some key features of that app, right? What would be some key features of that app? And so we are going to give you about 6 minutes, and then it actually turns out there's going to be a little bit of an announcement that may help shape your thinking, okay? All right, so use your notebooks, take some notes. What would be some key, what are you working on, and what would be some key features?
No, not downstairs.
right, y'all, 1 second. Bear with me. You're going to be back to your people in just a minute. First of all, I am loving the energy. Thank you so much for this conversation. Thank you. We're going to get back to it in just a minute. Now, but we have a plot twist. Now, listen, this is a simulation, but we are manifesting this into real life right now, okay? Like manifesting it, okay? All right, Michael, next slide, please. All right, we have a news flash. Simulated, but we're manifesting it. A benefactor who has a specific interest in reducing social stigma has agreed to fund your development. All right. Up to $250K if the app has specific features that address stigma. Okay, so relook at the features that you've already sort of agreed upon as a table and add in or sort of think about what are some further details that might help reduce stigma. Okay, so we're going to give you 4 minutes and then we're going to start to hear from different groups and we're manifesting, y'all. Okay, all right, 4 minutes.
Yeah, we have 3 minutes. She wants to start at 58. Yeah, we did do lunch for 2. Because that was our original. No, we did 150 and then 200. Should I go in front? It is what it is.
As you're hearing these features, I want to give you my best opportunity. But I don't know if you can hear us. Okay. All right, check. And like, something uplifting, like, wow, these are the kinds of whatever you want to say. All right, cool. So I'll make sure I give you, like a, just a nod and a movement before. All right, cool. Thanks. It's like they're getting. No, I just wanted to give you it because I'm going to go back up. All right, let's start to bring the conversation back. So listen, I know that this was a very short brainstorming session, but I'm glad you had a chance to get to know the people at your table, and hopefully you'll have more conversations over lunch. So now what we'd like to do is, we'd like to hear from you, okay? So we have a bunch of people with microphones around the room. So if you could share with us, what was the aspect of health that you chose to work on? And what were some of the key features? Let's keep it to no more than 2. key features of your technology. And hopefully we'll hear from many groups in the room. I see we already have a volunteer. Thank you.
Yeah, voluntold.
Voluntold. Let's give it up. Yes.
Thank you. So one of the features that came up in our discussion was that, as we were hearing from the gentleman who presented, that there's multiple priorities in one's life when they're, a Gen Xer. They're taking care of kids, they have a job, they're taking care of aging parents, they might need to eat healthy, they might need to walk. And so understanding, like in the setup of an application, what are those priorities in your life? How do you rank those? And maybe if you had to choose a health outcome that was important to you so that the app was tailored to your specific needs. The other thing that I think we were hearing inside the discussion is that there needs to be various features. Some people are motivated by just being really up to date on their own health education and are connected to, how many steps I took, or the types of medications I'm on, or understanding how to connect to my doctor. Others are motivated by, we were talking about streaks, right? I've walked a mile a day for the last 30 days, so I want to keep that streak going. Some are really motivated by fun and having a few minutes to yourself. And so an app needs to have some level of being tailored to one's specific priorities, but also what motivates them. Is it education? Is it games? Is it rewards? Is it streaks or socialization?
Thank you so much. I love that. Thank you for sharing. Did the plot twist, if you wouldn't mind giving the mic back, did the plot twist on double down on social stigma come up at your table?
Yeah, it did. So we were focused on HIV, but then we were thinking, what happens if I've been living with HIV for 30 years and it's well controlled and now I'm diagnosed with diabetes? That's a different level of, now we have 2 chronic conditions. Yeah. There's a lot of blame because I'm not eating right or I'm not exercising. So we were thinking around, just because you're someone with HIV doesn't mean you have stigma, right? You might have accepted that a long time ago, and that's not really the stigma. It's, oh gosh, I just now have 2 chronic conditions, and that's what's, so again, some type of assessment or where it could be based in evidence around, I don't have a stigma around this one disease, but now I'm feeling it somewhere else. And again, the app using some type of, we can call it artificial intelligence, but being tailored to the specific messaging that might be motivating to me.
Perfect. Thank you so much. This side of the room. Yes, thank you.
Hi, hello. Hi there.
Hi.
So our table here, we've decided upon a reminder app for our middle-aged clients that will help them with their daily reminders and help feeding them in with positive reinforcement. So that's been our focus within the app, as well as making sure there's some sort of proxy for the next of kin, or if they have a household member, and having a video interface that would help them reach their, what are they called? Healthcare providers.
Yep.
Or support staff that they involve themselves with.
Perfect. Thank you. And how did the news flash kind of play into your conversation, if at all?
The news flash came in a little later, so we added in the ageism since that was more of what we were focusing on in the beginning.
Perfect. Thank you. Back to this side. Appreciate it.
Thank you.
Over
I see
here.
a couple. Oh, yes. Hi.
Hi. So we had a great conversation, I think. We wanted to do an app, and we were thinking about, so what would somebody want out of an app instead of what we want them to do, right? So that's kind of how we approached it. And I think with older adults and, who come from a different generation, what I've heard in my career many times is that they want a sense of like community, they want groups that they can chat and talk to get that sort of support. So that was one of the features that we wanted to put in there, is that there was like a support feature. We also thought about avatars, so they could each have their own sort of avatar, which would play into the stigma role. So it would be open to all kinds of different avatars, non-binary, everything, all people with disabilities, however you want to build yourself. And then also we were thinking that with that message board, or however that communication would turn out to be, there would be maybe a daily question that that would be posted through the app, and it could address things like stigma and other issues that they may be dealing with, and then people can kind of like post that they're thinking about it. So yeah, we had a whole lot of other stuff too. But
Awesome. Thank you so much for sharing. Appreciate that. Yep. We're going to go here first, and then we're going to go to you.
All right, so hi, I'm Antoine from the AIDS Institute. Just speaking for me and my entire table, before we talk about the two things that we does this work?
Yep,
Okay, cool.
we're good.
That we chose, we came up with a name for our app.
Ooh,
And so-
manifestation.
We wanted to make sure that the name was inclusive and non-stigmatizing, and that definitely was incorporated into the newsflash. We wanted to think of a name that wasn't like HIV and this, or something like that. We came up with Thrive Plus, and so because the plus would tie into all the additional features, right, that come along with the app. We also, so this is our first one, was the socialization piece. We thought like having a forum on there, like a Discord, like somebody on the panel spoke about earlier, just talking about like different issues as it relates to life, or just seeking support, or meetups for coffee, or going on a walk, whatever that looks like. That's where that socialization activity piece will come in. And then another fun one that we thought was kind of different was just the health aspect alone, outside of like appointments and medication, but like tracking your steps, because everybody's into tracking their steps and things of that nature today. And somebody actually came up with at my table about connecting it to your Fitbit. I thought that was cool. If you could connect the app to like an Apple Watch or whatever other devices that you use, especially since we're talking about like digital technology, we thought that'd be cool. Again, another way to make it customizable, user-friendly, and all those cool things. So yeah.
I love that. Thank you very much. And maybe some of the avatars might be penguins. Who knows, right? All right. I think we have a report over here. Hello.
Hi, David Rosenthal from Northwell Health. We decided to create an app that we just named it because you came up with a name, so we had to. Hygeia, which is the Greek goddess of health and wellness. We kind of talked about creating an app where the app would get to know you at the beginning by asking some screening questions. And so figuring out kind of what's important to you, what your race, ethnicity, some of the things about you, what your gender identity, sexual orientation are. And then the focus is really to kind of connect you to a real and virtual case manager that would be able to provide support services that kind of gives you a voice. And so we would use an AI-generated avatar which would take pictures of you as the real case manager and would be able to then use certain preset answers to questions that would be able to come up quickly. Where can I find a food pantry near me? We can access that from our database, and we can give those sort of answers, but it would come from someone that looked like your case manager. And they would be speaking and talking to you like your case manager, so you could have filled that connection. And then if you wanted to then have a downstream opportunity to meet with your case manager in a real live interaction, then you could certainly do that as well. But it would also be supported by a back-end database so that we would keep all of the resources for referrals that are LGBT or that are HIV friendly, for certain social determinants of health things that would be able to access, that you could be able to have access to those things and be able to kind of add that information. But then as a case manager, you could also check in on your patients by looking at a dashboard and seeing who needed what from the app, how you could figure out what their needs were, so we could then proactively also reach out to those patients.
Wow, thank you so much. Appreciate that. I think we have a report out right over here.
I had the mic.
We're gonna, This is amazing. Okay, so first we're actually gonna go here, then there, okay? And then here. All right, manifestation. All right.
Yeah. Thank you. My name is Emma. I work at Stone River, and I talk with my friend Gary.
I'm Gary. I work at Boom Health in the Bronx.
Great.
All right, we are two community service. So the main key that we work with was location. An app that is always updating your location to give you resources to medication, pantries, any kind of service, social service that you could find in your actual area. Another feature, another key was medication and side effects tracker, where the provider had limited access, because how many of us go to the doctor, they forgot what I felt like 2 weeks ago.
Yeah.
So the provider could have access to see what you were feeling, like 2 months ago, and see if it's a continuum, if it's a pattern, if it was just a random, or is something that is happening. And for a stigma, reduce a stigma, an app with no pictures, not a specific age, so more like an age range, and provider education and resources for yourself identify.
Perfect, thank you. Multiple groups talking about, how does this app interface with like the real world and the real world challenges. I love that. Now I forgot where I'm going. We're gonna go here, then there, and then that's it. Unfortunately, because we're gonna be out of time.
Hello.
Hello.
So one of the things we were talking about, as someone who is from Gen X, I don't want another app. So one and one of is how can we merge the app into a existing app? Let's not reinvent the wheel. And you kind of see this in like some of the dating apps already, like Bumble and Grindr and Jag. Like some of these other apps already have health aspects to it, but enhancing that, and then making it more accessible, accessible to testing, affordability, and really around medication adherence and stuff like that. So.
Perfect, thank you very much. That's right, whatever we create will not be just another app. It's Thrive Plus, Hygieia, and then some, right? All right. We have over here, and then this table. Oh, you have your mic already. Sorry, we'll go here, then there. Go ahead.
All right, so William Chambers from Public Health Solutions.
Hello.
Hello. So one of the things that we kind of honed in on is this social support group, and I know that that's something that's been echoed from multiple tables, but specifically one thing that's different with the social support group is that for people who may be middle-aged but newly diagnosed with HIV, providing them with extra support. We did name our app Whole You, right, because we want to focus on comprehensively kind of whole person care, so speaking to their physical, behavioral, and their social aspects of care as well. So with that being said, providing affirmations in that social support group, a resource network, providing people with resources for housing, nutrition and food, and also transportation, because that's important, especially when we're speaking about HIV treatment. Another thing that we wanted to hone in on is the research hub. So that's something that's kind of new. So the research hub would be peer reviewed by physicians and things like that, and people who are in that realm. So public health professionals to kind of go through any kind of research, because we do know that stigma is a lot heavily based on misinformation. So providing people with correct information, true information, and then after making certain research digestible and palatable to that population. So for example, if they want to get on a new HIV treatment that may be better for them, then after they can have the research that's available to them at their footstool in order to make that informed decision regarding their health care. And then just, again, touching on that social support group, which will be a platform they can connect with many people. As was mentioned throughout this conference, that interconnectedness between human beings is really, really important. So giving them that social support group that connect them with multiple resources.
Thank you so much for that. Appreciate that.
Oh, hi everyone, I'm Jay from Housing Works. Not everyone at this table is from Housing Works. To start off, we named our app Concierge, or The Concierge, because we wanted to focus on everyone's social determinants of health. Is this thing on?
Yep, we can hear you.
Okay, so the main thing that we wanted to do was make it a one-stop shop for people to get on this app and be able to have access to the things that they need. So everyone kind of stated everything that we touched on earlier, starting with the groups. So there would be access to groups. These groups can vary from things like a run club or just getting people who sit in a coffee shop and talk. These groups are going to be the social hub for people to go to and find not only like individuals who are positive, but also spaces where they're safe and able to have community. 2, how are you getting your care? A lot of people don't know where they can find clinics when they're newly positive, or they don't know what's in the area. So similar to those apps, I got the idea from Sniffies to literally put a locator for different services on there. When we discussed that, however, something came up. What if you do not have it to go to the doctor? What if your needs aren't being met? So this is where the concierge steps in and finds you different resources and places within your neighborhood and communities that give you the things that you need so you can go and get the care that you need.
Amazing.
Yes. And the language.
You got this.
What else did we touch on? Groups. Oh, what do you mean by the language? Oh, yes. So the language and accessibility is one of the more important things. A lot of, like when we discussed earlier, AI, because technically this is AI. The Yoruba people did not know how to speak English, so they need AI to do that. With us, we wanted to make sure that the concierge is accessible to everyone in every language, so it would be more so readily available and accessible to people who don't speak just English and Spanish.
Amazing. Let's give that table and everyone a round of applause. So, Michael, if you wouldn't mind taking down the screen share, obviously you sit at the nexus of, digital innovation, inclusivity, and so there's a lot of goodness that we just heard, and I'm curious what's going through your mind.
I will say that I'm extremely impressed with what has been able to be developed in such a short period of time. The exercise that you just went through is called a design sprint, right? You went through a design sprint where you come up with this working prototype to be able to impact one's or communities' health and wellness. And I'm just incredibly impressed. One, with the energy, because innovation starts with energy. And the second piece is with intentionality, right? What I see is a lot of intentionality in the room, in energy and passion. And that's how you create new and innovative solutions. And what you all touched on, from personalization, creating social networks, leveraging AI, prompts, gamification, all of these different aspects create this powerful app or tool to be able to help individuals. But most importantly, what I'm impressed with is that you just created an innovation ecosystem in the room that you can take from today, carry that forward, and create something that can really impact the health and well-being of the populations, constituents, and families that you serve. So incredibly impressed with the ingenuity in the room, the energy in the room, and I'm just glad I was able to be a part of it virtually.
I love that, and I couldn't agree more. So, I work within the largest municipal health system. We have the privilege of taking care of millions of New Yorkers every year, and some of the things that you just described are going to be so crucial as we partner with all of you to take the best care of really New York City and beyond. And so certainly as a tech forward chief quality officer, I'm very excited, as Michael mentioned, to see these innovations and see how they might come to life. So with that said, thank you for your energy and engagement today, and it's lunchtime. And I will say, Michael and I both post a lot about technology, digital spaces, so feel free to follow us on LinkedIn, Michael Crawford, Komal Bajaj. All right, bye everyone.
Thank you, everyone.
It's actually not lunchtime yet. Sorry. You have to listen to me for like 5-10 minutes, and then you can go eat. So I'll make it quick. I know you're hungry, because I am too. We'll just wait for them to put our slides up. It's 3 slides, I promise, it's quick. All right, next slide after this one. We just debriefed, so that was great. Okay, so again, thank you all for coming again. We are the Digital Health Initiative, and we are embedded within the New York State Department of Health AIDS Institute, and we do a lot of this work. It was a really great segue to talk about app development, because we actually have made an app. It has a lot of the features that we all just talked about. You're able to message, whether it be one-on-one with somebody, whether that be a peer or a mentor or a nurse case manager, in some cases even a physician. You're also able to create these groups, so you can customize it to the needs of your organization. Also, it's your app, it's not ours. So you're able to plug and play different aspects of the app. So you can have information that presents itself in a very social media-esque way, so little blurbs, imagery, video, and you can tailor it to your specific needs. And it can work for the giant hospital network or a very small CBO. It can all be tailored to the way that you need it to be. We also have our comic, which is integrated into it. Next slide, please. All right, it's called Tested. You saw some of the characters from our comic a little earlier today. It has a very diverse group of folks. It's done extremely well. Next slide, please. I'm trying to go quick for you guys. I know you're hungry. The comic lives in digital spaces, which is the digital aspect of it. It's been viewed over 1.1 million times on a number of different digital health platforms, including the world's largest online comic forum, Webtoons, where it's created a community around itself. So some of the comments you see here are Webtoons viewers. It's been lauded. People tell their personal stories about the experiences related to whatever was discussed in that episode. We've been able to convey health information from credible sources that's accurate, which is extremely important in today's day and today's world. And it's been extremely impactful. So visit our table over there to learn more about it. Scan the QR code and read it, order it. It's fantastic. That's about it. So what we're gonna do is, as far as lunch goes, we're gonna break the room up. So we'll, Dr. Smith over there in the purple shawl. Go ahead and wave, Cheryl. All right, that's Cheryl. She will come and tap your table. You guys go and eat, talk amongst yourselves, and enjoy. Also, we have posters about digital health things that are very important and interesting. So we encourage you to go over and take a look, speak to the presenters, and enjoy. Hello. If we could get everybody to start making their way back to their seats, take that last bite, take that last sip, and we're going to get started again soon.
Check, check, 1, 2, 3. Is that louder? He's gonna give me some boxes. Check, check, 1, 2, 3. Hello. Hello, hello. Can I have this louder? It's on. It's on, but is it a little louder because this way I don't have to go close to it. Can you hear me here? Can you hear me in there? I can. You can? It's a little low? Okay. No? Hello, hello. Hi, everybody. I'm just talking. Make sure you can hear me. I think I have to go a little higher here. I have to go a little higher. Hello, hello. Hello, hello. Hello, hello. Okay, we got boxes. Let's see. That way. Yeah, that's it. You got it. And then the other one on top. Hello, hello. Are we increasing volume here? Is that good? Hello. Hi, everybody. Hi, how
All
are
right,
you?
so we have been overwhelmed and bombarded with a lot of digital stuff. So we're going to do something inherently not digital for our relaxation and get back into it session here. So I'd like to introduce Gillian Bell, who will be leading us in a meditation of sorts, and enjoy, relax, close your eyes, don't fall asleep.
Don't close your eyes yet, not just yet. But what I'd like you to do is probably remove everything from your hands. And if you're not facing me, maybe turn your chairs so you're completely comfortable in your seat. And really feel your feet placed on the ground beneath you so that the body is actually a chair, imitating a chair. Yes. Beautiful. And before you close your eyes, just bring your hands together. And let's just start to gain some energy within our hands. Because the healing is in your hands, right? And guess what? The body does not know it's not running, right? You are moving and breathing, and that is yoga. It's the idea of people coming together and moving and breathing. So that activity is happening now. And start to feel the warmth. Fingertips raised to the sky. Feel the strength in the arms. Feel the heartbeat meeting you there. And feel the warmth. Maybe a little faster. And notice the body. Notice the breath. Now stop. And try to bring the hands together, but don't let them touch. And feel that energy. Feel the healing energy that you have, that you bring to yourself. And put it now where you need it. Is it your head, the back of your neck, your heart, your shoulders? Where do you need the healing energy in your hands? Bring it there. Now relax your hands. And we're going to receive so that palms will be raised on our thighs. And now I invite you to close your eyes. Close your eyes, and if we can have the lights down a little bit, that would be really great. And listen. Soften your body. Listen. To the sounds of nature. To your breathing body. Soften. Soften your body. And breathe. Feel the feet and the connection to the floor and what has come before you being here now. The layers of earth beneath you. The softened sound. And soften your body. Feel the softening of the ankles and calves. Listen. Feel the breath and soften your body. Feel the release in the knees and the thighs. Soften them. Breathing bodies. Relax the buttocks. Feel yourself sink in the seat beneath you. Soften. 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 You are not your body. You are light and sound, embodied. Be light. And remember who you are. Be light, be light. Soften. Notice the fingers and soften palms of hands. Release them. Hold nothing. Breathe. Release the forearms, softened elbows. Relax your shoulders. Bathe in the sound of nature, within nature. Beautiful beings of light. Soften, 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 soften. Relax the throat and jaw. Release the mouth. Hold nothing. Listen. Breathe. Bodies. Soften yourself. Be light, be light. quiet canvas of your mind. Be light and soften. Deepen the breath. Start to open the eyes. Feel the palms on the hands. Inhale and do a full body yawn. Stretch the arms up to the sky. Pressing palms together, look up at the thumbs and release the jaw and throat. Relax the head back, let it fall behind you. On the exhale, inhale, bring the head up, ears between biceps. Reverse the palms, just feeling the internal rotation of the shoulders. Exhale, bring palms back, bring the hands down. Again, rub the hands together, awaken the body. We end as we begin with the connection to the healing hands that we have. Thank you so much for allowing me to walk you through this practice. Jar hands, just twist, release the wrist. A lot of computer work all day. Know how to release the wrist and know how to really activate the body system with all the work you do. Bring the arms up and let it rain down. Thank you. Have a beautiful
Thank you very much, Gillian. We appreciate that. Hope everybody feels enlightened and happy and great. Hope the shoulders are all loose now, you know? All right. Do we have a, okay. Okay, it is my pleasure to now introduce the final stage of life. This sounds super depressing, but the more sober and experienced folks and how they interact with digital tools. So the session is entitled Aging Gracefully with Digital Health in the Silver Years. We'll have 3 different presentations, starting with Greg Olson, followed by Ipsit Vahia, Dr. Ipsit Vahia, and then followed by Dr. Nema Ruhi. If we could get Dr. Olson, or Greg, come on up, wherever you are, Greg.
Testing? You guys hear me? How we doing this afternoon? All right. See that picture? I haven't looked like that in about 12 years. And I stopped wearing suits after the pandemic, so you have to bear with me. Well, it's great to be here. My name is Greg Olson. I'm the director of the New York State Office for Aging. Just quick by way of background, geriatrically trained social worker. I've been working with older New Yorkers for 33 years in a variety of capacities, direct service provider, community organizer, ran a bunch of not-for-profits that advocated on behalf of older adults. I was chief of staff for the Assembly Committee on Aging for 4 years, and I've been at the Office for Aging for 18 years. Is this the clicker right here? Yes. Which button do I use? There's like 3 green ones on here. Is it the big green one with the triangle on it? Yes. All right, I can't see the presentation, so if you guys are cool with me jumping down, that's what I'm going to do. Well, it would be backwards there, so I'm not going to be able to see it. The middle one? Oh, laser, really? Sweet. You know, it was interesting. I came in when you guys were doing the round table, and you were coming up with a bunch of solutions based on a variety of different experiences. And you guys are spot on, but I'm going to tell you a lot of what you already talked about not only exists, but we have been implementing now. We're going into our 7th year. So I have implemented since 2018 31 public-private partnerships with tech companies. I'll start by saying older adults use tech at the same rate as everybody else. AARP does a survey every year. So as of January 24, older people are using tech just like you and I are. So I want to make sure that we level set that the traditional stereotypes about older people are certainly not true. So why did we get into this? I'll just tell you a little bit about our agency. So what I'm responsible for is overseeing a network of 59 county offices for the aging. We work with 1,242 not-for-profit community organizations for the sole purpose of trying to keep older adults as independent for as long as possible in their homes and communities, supporting their families. But there's more to it than that. Older people don't just live at the Office for Aging. They touch, bless you, they touch every single system. So I have 32,000 veterans on my caseload. 70% of the state's veterans, 440,000 are over the age of 60. Got 19,000 older adults with a diagnosed mental health issue, so we have to work with OMH. We have 8,500 people with alcohol and substance abuse. Don't even get me started with problem gambling. So I have to work with OASIS. We just did a webinar on the benefits of cannabis in older adults, so we're working with the Office of Cannabis Management. And I could go on and on and on. The SNAP program, HEAP, is through Office of Temporary Disability Assistance. Adult Protective Services is in Office of Children and Families. And so part of my job is to really leverage resources to be able to serve as many people as I can and expand. So where does tech come in? Again, tech is not designed, at least in my mind, to replace a human being. There's always going to need to be that interaction. However, if we go back to older adults are using tech at the same rate as everybody else, through my 31 partnerships and projects, and one of my favorite ones is going to be presenting here today, Nemo with Blooming Health. We're serving 1 million more people for literally pennies on the dollar that are really plugging really important holes. Now, it's not going to be a platform or a service that everybody is going to benefit from, but overwhelmingly, they do. Now, I'm going to talk fast. I have 15 minutes. I don't know who the timekeeper is. If it's over here, then I'll just keep looking that way, and then it doesn't exist. But you guys are more than welcome to shoot out the slide deck afterwards if you want to see these, because some of the things that I'm going to, oh, it's you? All right, so I'm going to go on this side now. Some of the things I'm going to talk about today are actually free, that I fully subsidize for any person over a certain age, and I'll walk you through those. Others we're piloting. I heard the person, I think from Brown University, talking about the trust factor. How do you measure? Can you trust the measurements? You can, and we are. So the first thing I'm going to point you to, and this you can find on my site, I published this about 6 months ago. This is 18 of our 31 projects. It's a super easy read. Aging.ny.gov. You can go and you can take a look at it. And what it does is list some of the projects that we have. They're all one-pager. What it is, who it targets, what's the intervention, and what are the outcome measures. I don't partner with anybody unless we're measuring it. And so they're all measured. So I understood what his point was, but our point is we do have historical information on use, on satisfaction, and outcomes data. So you can take a look at that. Now here we go. I'm going to go fast. So our first one, since 2018, we implemented. This was prior to the pandemic. What happened in 2018? August 2018, CMS and AARP put out a report that talked about what the impact of loneliness and isolation are for older adults. You've probably heard it. Equivalent to smoking a pack of cigarettes a day. Costs Medicare $7.2 billion to treat. The amount it costs to treat is the equivalent of hypertension, diabetes, obesity, COPD, and so on and so forth. So these are lifelike plush animals, cats, dogs. They now have a walker squawker that actually prevents falls
and trauma-induced from falls, as well as intergenerational games. This model that I developed in 2018 is now replicated in 47 states. We've put out 37,500 pets to lonely and isolated older adults in their homes and communities since 2018. It's an amazing project. Intuition Robotics created a proactive AI companion called LEQ. And what LEQ does is it, like I said, it's proactive. I have one in my kitchen. When I get up in the morning, first thing it says to me is, "Hey Greg, how'd you sleep last night?" Why did it ask me about my sleep? Because when I plugged it in and got it, we started to develop a one-on-one relationship because I'm unique. It's going to be different for you. It's going to be different for you. So it knew that I don't sleep very well. Then it asked me, "How's your back feel today?" Because it knows that I have degenerative disc disease. What this is designed to do, again, is be a companion to older adults, but there's been so many additional features that have been put into it in terms of exercise, health and wellness, hydration, so on and so forth. We've seen a 95% reduction in loneliness and isolation over the last 4 years, and a 97% improvement in overall health and wellness. And again, you'll see this in the report. Get Set Up is free for anybody 50 and over in New York State. When we launched this about 3 years ago to today, we have 700,000 users, which costs me about 50 cents per person per year. Just let that sit in for a second. I have more change in my car that fell out of my pocket than what it cost to help somebody. This was designed during the pandemic to really bridge the digital divide and teach older adults how to use the equipment they have, a smartphone, a cell phone, a tablet, a computer. What it has now is over 5,000 classes, lifelong learning, anything from cooking to photography to taking trips, etc. But what I find most fascinating over the last 4 years is the top 10 classes are all health and wellness, which says to me, older adults really want to maintain their independence. They want to improve their health. Things like sleep, anxiety reduction, morning Tai Chi, exercise, etc. Anybody over 50 can go to my site. It's free. But there's also an economic opportunity for people over 50. If you have a skill, now I'm 56, I don't have a skill, but if I did, I could sign up and teach a class. So now, in all seriousness, I play guitar. So if I wanted to teach a guitar class, I can sign up through Get Set Up and actually get paid. So it not only combats loneliness, isolation, lifelong learning, health and wellness, etc. It's free for anybody in New York State. Virtual Senior Center, for those of you that know self-help. Oh my God, are you kidding me? I got 4 slides to go. Self-Help created a virtual senior center about 6 years ago that I helped them with. We brought that in the programming up to 20 counties in New York State. Travolta and Archangels, these are evidence-based caregiver platforms. Both of these are free for anybody. So you can scan that QR code. The Caregiver Intensity Index takes literally less than 2 minutes. And it's for individuals who are caring for somebody else. And you could take it as many times as you want, and it gives you a score. You're in the green, you're doing good. You're in the yellow, not doing very good. And people who are in the yellow, 7 out of every 10 have some type of mental health issue during that journey, or red, you're in crisis. And then we connect people to a variety of resources like Travolta, which is an evidence-based caregiver platform, which again is free for anybody in New York State, where a couple of things, let's say I'm caring for my dad who's a sundowner, the types of education and training I'll get come in snippets that caregivers want. 5 to 7 minutes, audio, video, written. Let's say I'm taking care of somebody who's a younger disabled individual. The content that I get is based on who I'm caring for. These things are free for anybody, so please get them out. They're incredible. And again, in our guide, you'll see what the outcome measures are. Now I'm going to start kicking into it. Can you give me 5 more minutes? GoGo Grandparent is a specialized rideshare program for older adults. It uses its own driver, Lyft and Uber. So we've patched that into about 37 counties, mostly in upstate New York. 95% of New York State has no public transportation. And this has been a huge stopgap. So you guys know Long Island. our Nassau County folks are using it to bring veterans to SUNY Stony Brook, where the Veterans Hospital is. Would not have that option before. In the Finger Lakes, it's 85 miles to the closest occupational therapist. They're using it for that, so we've been able to do that. I'll skip over the next one. We're the only state in the country that partnered with the National Association of Home Builders to train our 850 case managers as a certified aging in place specialist. So when they go into their home to do their assessment, they're looking at things that are going to create falls, potentially traumas versus falls, and we know what happens when people falls. I think I'm the only state in the country that mandates my case managers are state certified or we don't pay them. Discover Live. These are more for isolated people who are mobile. We have this in 101 senior centers and NORC programs, not only in the city but throughout the state. And what folks are able to do is get a 1 hour in about 220 different locations around the world, like Slovenia. You could go to Hawaii, and people pick where they would like to go and do a professional tour with a tour guide on the other end in any and all languages. What we have found, again, the social engagement, bringing people together, trying to get people to make friends, etc. They get one of these every week for 52 weeks. The cost to bring just into one senior center for an entire year is $520. Relish Memory Lane, TV, Zinnia, and Map Habit are all designed for individuals with cognitive impairment and their caregivers. So these we're doing through federally qualified health center, Alzheimer's Association, social model adult day programs. Relish are products that are designed, again, for people with cognitive impairment. Memory Lane TV and Zinnia are TV-based, but also have a lot of caregiver support, training and education. And Map Habit actually is what it says. It was designed for people with IDDD. Now it's been shown proven for people with Alzheimer's that you can relearn your ADL and IADL tasks that take pressure off of the caregiver. Again, all of this is measured. You can see it in our report. Blooming Health, Nima's going to talk about that. I won't take his thunder. Team Vivo, if you're interested in falls, I got a call from SUNY Albany, SUNY Stony Brook, when we're embedding this within there. That's a strength training program. It doesn't matter how old you are. If you're doing, 1 minute, strength training, the nutrition, you can build muscle mass and reduce falls. I got a note and a picture from a woman in Rochester who thanked me for allowing her to be a part of this project, and said she hadn't left the house in a while. She had fallen a few times, was afraid of falling. The picture she sent me was of her skydiving at 95 years old. Better Age is one of the things I am most hot about. So when you talk about Blooming Health, Better Age is a public health solution that actually measures where older adults are thriving, struggling, or in crisis. And so when I go back to what I came in on, when we're talking about how do you design something for somebody, you can't do that until you actually know what it is that they need. I can, again, based on my years of experience, say, well, I think this person needs this, I think this person needs that. This is actually 9 different evidence-based ways to self-report where you are, from financial literacy to housing to transportation, so on and so forth. On screen, very similar to Zinnia TV. We're just doing that with Alzheimer's Association patients, different environment. Oh my God, I'm done. All right. Yeah. You guys, can you send out these slides out? Yeah. Okay. So, and these are other. I just do want to talk about these last two, EverSafe and Fraud Finder. Scams and financial fraud cost older adults between $28 and $52 billion a year, depending on who you're going with, AARP, the FBI, et cetera. So the Assistant District Attorney in Manhattan, Liz Lowy, she's retired now, prosecuted these cases for 30 years. Her and her partner came up with EverSafe, which is a platform to protect financial and other information and red flag stuff. There's a new one called Safety Shield that I'm going to be launching sometime in the fall. Fraud Finder, because we're the only state in the country that has what's called an EMDT, an Enhanced Multidisciplinary Team Approach to combating elder abuse and financial fraud in all of its forms, was designed by our forensic accountant, where you could put mountains and mountains of financial data into the system to look at irregularities and red flag. Why is that so important? Because that type of financial data, if you're a single human being, takes a really, really long time to go through. So for every one person I could do singularly, if I was an accountant, I could do 1,000 people through this. And again, you can read these if you're ever interested. Here's my point. Here's my takeaway. There's some free stuff here. Take advantage of it. Number two, there are a lot of solutions that are already being implemented, not only in New York State, but elsewhere. We are the leaders in that by far, and I'm really proud of that. Number three, older adults use technology. They can. If they don't, they can be trained and supported to do so just like you or I. I'm not a tech person, but I can do the same things that you guys are all doing with your phones, et cetera, et cetera. So these solutions work. I've worked with a lot of healthcare providers, payers, et cetera, that will not take the risk and purchase these things. Not quite sure why that is, but they are not risky. They work, and look at our report, and we will show and demonstrate that that is absolutely the truth. Thank you. Sorry to talk so fast. I knew I only had 15 minutes.
Thank you for giving us that great rundown of all the programs that New York State is doing and for all your work. Thank you. I'd like to invite Dr. Ipsit Vahia to tell us about what he's doing. All right.
I was asked to stay on the podium, so I will. Yeah. I should tell you, I caught an error on my title slide. I am not on Twitter anymore. I don't know why I didn't erase that. Haven't been for a while, so don't look for me there. So quick audience poll. How many clinicians in the audience? People that work with patients? A few. How many people based in academic environments? A few more hands. So I'm a clinician, I'm an academician. We had a fantastic talk just now from someone that works in the public sector and someone in the private sector after me. So we're in between. I'm going to give an academic clinical perspective on aging in the context of mental illness, in the context of dementia. And hopefully across the three presentations, it will fit into a broader understanding of how all of this works, what kinds of problems are solved in which environment. That's just my disclosures. Usually I rush to this, but I'm also a nerd, so I point to the last line because I'm the only psychiatrist I know to have gotten funding through NASA. Thank you. I like to start with this because we think of AI as this new, shiny, revolutionary idea. And the technology itself and the tools we're dealing with maybe, but the ideas are not. So these are two examples, one from Eastern mythology, one from Western. On your left, you have a picture of the Pushpak Viman, which was a palace that belonged to the Hindu gods, where you could get into the palace, think where you wanted to go, and the palace would take you there. No driver involved, much like self-driving cars these days. Old concept, new implementation. On the right is Talos, the bronze giant protector of Crete. Here you see him attacking Jason and the Argonauts when they landed there. Talos lay curled up on the beach until a force that he determined through some sort of algorithm as hostile came, and then he would attack them, much like sentient robotics. So we're talking old ideas, well-formed ideas, but with new implementation. In care, though, the question often is asked that care is essentially a human act. Are data a good thing? We looked at this. These are some data from a study we did where we looked to see if giving clinicians a dashboard of data from patients, electronic and social media changed the alliance. That's a complicated figure, but what it basically tells you is that the alliance neither improved nor worsened. We would have liked to see it improve. We were afraid we'd see it worsen. We saw neither. So using more data in the context of human care does not seem to impact the relationships. So how might it look if we were working in a very data AI intensive environment, right? I'll tell you the story of Mrs. E, who is an 85-year-old woman, lives in an assisted living facility in the Metro Boston region. I happen to be her treating psychiatrist. She has a diagnosis of major neurocognitive disorder, major depressive disorder, and generalized anxiety. She also has a history of pacing, restlessness, and agitation. Now, an interesting thing happened. Every time I would go to see her where she lived, I found that I was entirely dependent on the staff there to understand how she was doing. And this data was summed up usually in 3 words. She's okay, doc. Or she's fine. And everything was fine until one morning she punched a peer in the face at breakfast and found herself in the hospital. This made us think that was this really a random event which you can have in dementia? Or had something happened that was missed? Now, in Boston, we have a tech ecosystem and a hub, including MIT. So we reached out to see what tools we could find that would let us watch these people without actually watching them. What you see here is a device we worked with called the Emerald. It's a non-specific looking white box, but it's very powerful. It emits radio signals and functions as a sonar. So what it can do is it can track a person's movement and behavior in their living environment. It makes no sound. It emits no light. It's plugged into the power main, so it does not need to be worn. It does not need to be charged. When you work with older adults, you really want to make your technology invisible to the extent possible. Here you can see our volunteer is walking on that spiral, and he's that red dot on the bottom left. So the device is behind the wall. Because it's radio waves, it can penetrate walls. And it tracks his movement accurately. It can track gait speed, gait patterns. It can even track spatial location, speed. And if someone is still, it can detect breathing rate based on just chest valve movements. It's extraordinarily sensitive. What this does is it can tell us things like this. It can tell us when someone's having a low activity day versus a high activity day. This is not yet commercial grade technology. So with so many powerful tools here, we heard great examples of how these are being implemented in the community. But AI is a little more complicated and resource intensive. So we're really at the point where we're now trying to find interesting and important ways of using these technologies. These are examples from 2 of our ongoing studies. This is a project where we're looking to use a wearable device every time we make a medication change for someone with dementia. Now, usually if you make a med change, you have to wait until the next visit to find out what happened. Did it work? Did it not work? Was there a side effect? Using wearables and the system we've built, now you can get data telling you that I increased this person's sleep medication yesterday. Today I know whether they slept better, if they slept worse, if they slept for 17 hours, did they sleep for 3 hours? And you can make the change the next day. When you work with older adults, the risk of a fall or the risk of a side effect is dramatic. Takes work to weave all of this into clinical workflows, but we're getting there. This is another example of just demonstrating how using an AI chatbot to do assessments, not to provide care, but to do assessments, how it can change the efficiency of a single visit with a care manager. So say someone with dementia goes to see a social worker. The black check marks tell you what you can reasonably accomplish in the first visit. The green is what might happen when you use AI. Basically, the bot takes care of the 2 biggest information gathering stages, allowing the human to solve 3 problems rather than 1 when they might have. AI will not replace humans. No one that's asking the question need worry. But we do think that humans that learn how to use AI will do better than humans that don't. So how is all of this going to get implemented? The truth is, specific solutions for specific problems. A lot going on in this slide, but this is basically a table that demonstrates using HIV and AIDS care as an example that there isn't a one-size-fits-all solution. Every single piece of the clinical process, be it assessment, be it care support, be it medication management, be it connecting to resources, may be enhanced using some specific piece of technology. And with AI evolving, this is starting to become even more specific. So right now there are experts in AI. In reality, there is no such thing. You may be an expert on using one type of AI for one type of problem, but there are no global experts. So there's multiple inflection points. We're at a really interesting moment in time. Hopefully the more skeptical amongst you are asking questions like, it's fine to do this in a place like Harvard or Mass General Brigham or in a very academic, resource-rich environment. We asked the same question. So this is a fun study where we took a virtual reality intervention that we were developing, And we tried to see how difficult we could make this for ourselves. So we decided to see if this can work in a lower middle income country, in a rural population, using non-English speakers, in low resource ecosystems where there's a lack of access to technology. It's really hard to read this backwards. Using cheap tech. And we wanted to see if we could do this without actually giving people our tech. So based on what existing infrastructure there was, and to disseminate this as widely as possible. We have a collaboration with the Universidad San Francisco de Quito in Ecuador. We used a virtual reality device that costs $40. You could find it on Amazon. You could buy it on your phone now and have it waiting for you at home this evening. It's called the Destech. It uses the smartphone as the technology. Turns out, even in rural, remote Ecuador, there is still cell phone signal and data. So using this, we did virtual reality-based mindfulness. Not as good as the mindfulness we did a few minutes ago, but it'll do. It'll do. Tech is also changing our language. These are the DSM criteria for major depressive disorder. Under the current law of the land, you have to have at least 4 out of 9 symptoms to meet criteria for major depressive disorder. In reality, it doesn't work that way. People can have 1 symptom, 2, 3 symptoms. They are disabling. And now tech is allowing us to measure each of these independently. So you can treat just apathy. You can treat just insomnia. So big gaps and big opportunities. This is exciting stuff, tremendous potential, lot of challenges. Right? I usually like to say, if you really want to know how this goes down, buy me a beer, maybe 2, then I'll talk. We are good at gathering data. We are not quite as good at merging big data sets. We are still figuring out how to ask the right questions that AI-based data can answer. There's a lot of practical issues in storing these data. There are unknown costs. There are hidden costs. That's just the research part. When it comes to clinical implementation, we're looking at a scenario where our entire lexicon of mental illness may quickly become obsolete. So we need new ways of incorporating these data into clinical workflow. We actually need to figure out, how does all of this data actually impact patient outcomes? We can gather all kinds of things, but is it making things better? How is it impacting decision making? We're still learning that. We need new training. We need new clinical guidelines. We need new treatment guidelines. And we need to train people to learn how to deliver care using this data rather than doing it post hoc, like my generation of clinicians is doing. And finally, policy. Not nearly enough time to get into this, except to say that transparency matters, trust matters. There need to be regulatory frameworks for using AI. We are far behind, partly because AI evolves faster than our usual mechanisms for research can keep up. If I want to do a study using a particular AI-based tool, odds are, before I even write the grant, much less do the study, the tool may already have been replaced by something else. So I'll stop there and leave you with the idea that in the end, where is AI going to be most useful, right? People like the folks in this room may or may not be the drivers of those decisions. Those are made by the likes of Silicon Valley or Wall Street, et cetera. But the truth is, it's people that work at the grassroots that need to have a seat at the table. If they don't have a seat at the table, force your way to it. Because we are the gatekeepers of how this is going to play out. And nowhere is it more important than aging care. We spent $350 billion on dementia care per year in the United States alone, right? $350 billion. For context, McDonald's makes $30 billion a year. So dementia care alone costs enough to bankrupt McDonald's 10 times over each year. Everything in healthcare is important. Everything in mental health is important, but not everything can pulverize entire economies the way aging care and dementia care can, right? So our most powerful tools should be leveraged for our biggest, most intractable problems. And if we get that right, we can apply those lessons to every other demographic. Thank you.
Thank you, Dr. Vahia. I'd like to invite Dr. Nima Ruhi up. I saw you. You're very tall. There you are. All right.
All right, good afternoon. Hope you guys all enjoyed the meditation session. Would have loved to take a nap afterward, but here we are. Before I get started, I want to mention that Dr. Vahia, pretty amazing research work. We should partner, I think. We'll talk about some of the implementation of the stuff you talked about at the scale across the United States in a second, but I think there's interesting synergy between the works. Before I get started with my presentation, I want to mention I'm Nima Rui, co-founder and CEO at Blooming Health. Blooming Health is a technology company born out of New York City at the peak of the pandemic, when the city was under lockdown. So me and my co-founders actually started a company to help some folks, like our loved ones, to get some basic care, like a meal delivered to them or a prescription refill delivered to them, or a ride provided to them to get to their next healthcare appointment, especially older adults. We launched in East Harlem as the first kind of neighborhood where we started working. And so full circle, coming back, talking to the New York digital health community means a lot to us. We appreciate the opportunity. So just to get started, I want to actually pick back up from where Dr. Vahia was talking about some of the interactions between a care manager and an older adult when you're providing care to them. So the focus of my conversation, or the data I'll talk about, is really primarily on everything social care. So if you think about the ecosystem of healthcare, broader healthcare ecosystem, basically, when people leave the medical facility, they still have some needs. Someone that gets discharged from hospital, an older adult that might need to get to their next healthcare appointment, someone that might need home health, or if it's a low-income population, might be evicted from their home and need housing. All of that drive healthcare outcomes. Our mission at Blooming Health is really making those services as easily accessible as tap water in every household, especially for older adults that are highest risk individuals. Now, in order to deliver that type of service, every individual needs to kind of navigate a very complex process. There's multiple different stakeholders in the healthcare ecosystem. If you're a dual eligible population, you probably have 15 care managers. With every care manager, you're navigating a multi-step process of receiving care, from becoming educated on what type of benefits are available to you, to going through screenings, enrollments, referrals to organizations that can provide services to you, follow-ups to make sure you got the care you needed. If you're a care manager providing this, you need to spend hours on this on a span of multiple weeks timeline. Now, if you scale this up into the growing aging population in the state of New York as an example, how many of those care managers you need to actually successfully help these individuals get some of the basic care they need. So understanding the challenge here, we at Blooming Health decided to actually build an inclusive and equitable technology solution that I'm going to talk about 2 case studies today and what the outcomes were. Basically, our platform connects the population to social care providers, the neighborhood senior center, the care managers at their MCOs, the area agencies that are aging in every county. We have an AI agent that can automate the workflows of care managers, can speak any language the older adult speaks. The older adult do not need to go to a website to talk to it or install an app. We could reach people on phone calls or text messages, even if they have a landline. This is important. Dr. Vahia mentioned that actually in rural Ecuador, you can get people smartphones. Believe it or not, in rural New York, you have people that do not have access to broadband and cell coverage. The only thing they have is landline. So in order to build an infrastructure that is resilient enough to reach everybody, we've built this kind of omni-channel, multilingual AI solution that can reach you no matter where you are, no matter what language you speak. we started kind of partnering with a lot of the folks on the front line of the care providing, the community-based organizations, the food pantries, neighborhood senior centers, housing operations, and we started scaling this up across the nation. Today, we're in 22 states, serve around 1.5 million people, and we partner with government entities like State of New York, Greg Olson talked about it, City of Los Angeles, Dallas, Houston, and a lot of systems and health systems and healthcare stakeholders across those areas. In the state of New York, this is our footprint. We're in 43 counties. We've partnered with more than 580 different organizations across these counties. So through area agencies for the aging and all the contractors they work with. 45% of our population are living in rural areas. Around 47% of our population actually just have access to voice calls, a landline. So these are older adults that do not even have a flip phone. And the platform basically enables reaching out on all of those individuals for the organizations that are serving them. This is a little bit more statistics on the population and the kind of percentage of people that we have on voice overall, the older adults that we have overall, the percentage of people that are feeling social isolation and loneliness. Given I can't see the screens, I didn't memorize all the numbers, so you can see it here. But I want to jump into the case studies because I think this is the interesting part. So I'll talk about two case studies, one with New York State Office for the Aging, one with AARP Foundation. With AARP Foundation, we basically wanted to study if we put a automation platform in the hands of community-based organizations in 10 states and help them reach more people, can we actually create outcomes in terms of health and wellness of the older adult population and in terms of the needs we're addressing for those population, basically. So basically, we rolled out our platform into 10 states, around 150,000 people. These are all 50 plus years old, all low-income older adults, basically, so high-risk, dual-eligible population. The objective here was to make sure these older adults get connected to food, housing, transportation, public benefit when they need it, where they need it. And the idea was to use AI to make this accessibility 24/7 available to the people. So they don't need to kind of stand on a line. They don't need to call a number 10 times before they get kind of connected to care. They don't need to fill up a bunch of paperwork. They don't need to bring in a translator or their kid into the session in order to talk for them. Through this process, after 12 months, so we had 150,000 people as a part of this, and then we had some holdout population to test A/B how people behave when they're using the platform or they're being helped with the platform, and people that are not. We saw 500% or 5 times more enrollment in food stamps, as an example. We saw more than 7,000 benefit enrollments, around $11 million worth of enrollments in public benefits. More than 70,000 rides were provided to the older adults. This could be through like examples of Go Grandparent that Greg talked about. It could be voluntary ride providing. It could be integration with Uber Health or Lyft Health and getting the older adults right to their healthcare appointment paid for by their healthcare. The point though is if you digitize that last mile delivery, you can actually scale up accessibility much more and create a lot more outcomes. In fact, if I move on to our case study with State of New York, I have only 2 slides, so I'm going to wrap it up. If we talk about the case study in the State of New York that I think is would be interesting to the audience here, every county has their own area agency on aging that contracts with the State of New York, with Greg's office, basically, to provide social care to the population in those counties. This is one of the kind of, if you're not an older adult, unknown stakeholders that actually plays a very significant role in making sure older adults in the communities are getting cared for. If you talk to your parents or grandparents, they probably trust their case manager in their neighborhood senior center more than they trust their primary care doctor. They might not say to you, they probably trust them more than trust you. Not trust as a kind of a quote unquote trust, but like they don't want to overwhelm you or put more kind of feeling of guilt on you by sharing some of their problems. But they'll open up to their neighborhood senior center case manager or their area agency for aging case manager. So by putting this digital platform in the hands of these organizations and their staff, we enabled them to reach a lot of older adults that were overlooked by technology, people that literally don't have any digital solutions in their home. They just have a landline. Some of them might have flip phones, and use the power of AI to generate more scalability and equity for access to services. Again, in this process, we saw a lot of impact in the service utilization, from people actually getting access to public benefits like food stamps or Medicare saving programs, to people getting access to meals and nutrition, home delivered meals for people that are homebound or people that might be low income going into the congregate meal settings, all the way to getting them connected into all sorts of programs, whether it's digital or in person, that Greg was talking about, or provided by their local health system and healthcare providers, which actually had some measured outcome. Reduced 10% social isolation and loneliness amongst these older adults over the course of 12 months. Again, this is measured compared to their baseline. Around 7% improvement in self-reported health outcomes, basically, for these older adults. So if you get an older adult that is diabetic, access to meals when they need it, especially if they don't have the movement impairment they have the movement impairment and they can't stand in the kitchen or cook, or they might be low income and not be able to purchase healthy food and end up buying McDonald's, and that actually pushes them into getting into ER or hospitalized. By investing in this services early on, using digital, like equitable digital infrastructure that actually can collect data in a timely manner, dispatch service in a timely manner, you could save that one ER utilization. It pays for 1 year of this individual's meal being delivered to them to their home, basically. So this is really kind of the type of impact that we were able to see at scale when you have that type of equitable digital infrastructure in the communities. As I mentioned, this is now available in 22 states. We are in a kind of inflection point of our growth. We are trying to get to around 10 million people by the end of this year. A lot of it is going to actually happen in the state of New York, hopefully, given how deep we are in different areas here. But one thing I want to leave you with is this. When we started the company, we actually created a cell phone app first. Like the first thing we created was a cell phone app. We thought we're going to get older adults on it and get them care they need. First of all, it turns out that most people that need the care and are of highest risk are not on cell phone apps. Second, we learned very strongly trust is a huge element in digital health. If you're building a product, if you're researching the behavior of a certain population, please take trust as an element into account. This is why the community element, the frontline element here matters. None of these older adults actually know Blooming Health exists, because it's all white labeled to the brand of all those community-based organizations on the front line. When they receive a call, the caller ID shows their neighborhood senior center name. When they pick up the phone, we have actually recorded voice from the staff at the senior center that greets them to the call, to make sure that we can engage them, help them trust that organization, or accentuate that trust at a scale, and be able to use that channel to intervene when they have any. I'm going to stop here. I appreciate everyone's attention. Thank you so much.
Thank you very much, Nima. Now we'll have a Q&A section, and I'd like to invite the previous speakers up. So Ipsit and Greg, come on up. And audience, please ask your questions.
For all doing that, but I was wondering, how do you help this generation find out that these programs exist, and how are you spreading awareness about them, since I know a lot of these people aren't as connected as the younger generations?
So the generation is talking about older adults, and what services are we talking about?
A lot of the ones that you were talking about.
So the pilots we did are our general book of business.
The general book.
Yeah, I mean, it's a great question. So for those of you that don't know, there's a state office for aging, county office. It's not your fault. I've heard over 3 decades, you don't do a good job in doing outreach and education on what you do. That is patently false. We all, if we're working in healthcare or social services, it's a crisis-driven, line of work. You don't need to know what you don't need to know until you need to know it. So, I think through, Blooming Health, some of the things that we're doing, I mean, we have 25 core services in every single community around the state. We're out there both at the state level and local level, but the bottom line is people aren't looking for what they don't need until they need it. 2 examples I always like to give. You don't need to know about Star property tax exemption until you buy a home. You don't need to know about TAP and Pell until you send your kids to school. So it's not for lack of trying. It's people do the best they can. They wind up in a crisis, and then they get connected to us, unfortunately.
Thank you so much.
The irony is that AI is really good at telling you where to find AI. I kid you not. We've been encouraging some of our patients to ask ChatGPT where to find this and that, and it does a very good job.
Hi, over here. Really appreciate all the presentations, fascinating discussions, and love the idea of public-private partnerships. I'm curious how you handle privacy and what ways you use to communicate how data is being shared, stored, reused, et cetera. All of you.
I can get started, and I'll pass it to you.
I mean, I could start just from a state agency. That's the first question, right? We're not partnering with anybody that's sharing individualized data. It all has to be HIPAA compliant. Now with AI, given that Governor Hochul has put a lot of money into this, wants New York State to be the AI capital, all of the AI tools have to, at least that we're using either externally, some of these, or state agencies are implementing directly, have to go through risk assessment reviews. But we won't, the data that we get, like what Nima showed, is aggregate data. It's not Mrs. Jones who lives in Chautauqua County on this road. So that's the first question, because I'm not partnering with anybody that's doing any of those things with data. That people's privacy is my #1 priority.
Yeah, what I would like to add here is in this day and age, if you're building digital health products, privacy security is probably the very first problem you need to think about, because the rest of the technology is, I would say, commoditized to some extent. And that's why I emphasized on trust. So I think there's 2 components here. One is how technically can you encrypt data, protect data, make it safe, et cetera. That's actually a technical problem that is not that difficult to solve for. The second one is really to have proper firewalls between different stakeholders. One of the key problems that is arising in the world of social care within healthcare is patients are sometimes hesitant sharing information because they don't know who that data will be shared with. In maternal health, as an example, and they might feel the risk for that. It's the same with older adults. So what we have been doing is actually kind of overkilling it. So Greg requires us to be HIPAA compliant, but we are high trust. We're SOC 2 compliant. We actually have a information security officer that audits every 3 months all of our platforms, all of our databases, et cetera, and we have reports available to all of our partners to be able to track that. I think transparency and having systems in place from early on as you're kind of building these infrastructures in the communities is going to be a potential solution here, especially in the age of AI. We already have enough skepticism, so let's not really add to that.
We think about this a lot because we do mostly research. So in fact, we are collecting fairly intrusive data on most of our participants. So there's complicated ethical questions there. What is the line between monitoring and surveillance? How much data do you really need? Do you need everything, or do you only need what you need when you need it? if I had the answer, I would be very wealthy. But the one hack that we came up with that has served us well is any technology we use to gather data on older adults, we give them the off switch. So it turns out if you don't do that, people will not consent to participate in any of your work. They will not use your tools. If you give them the off switch, they tend not to use it very much. So I think giving people that autonomy and respecting their ability to decide what data they give you or don't give you matters quite a bit.
Thank you very much.
So just a quick question for everybody in the room. How many of you have someone who is in the silver population that you interact with on a fairly regular basis? All right, everybody. How many of you have been that designated person who is required to, hey, can you help me set up fill in the blank? So my question is related to that. What tips do you have to help avoid that interaction devolving into frustration and eye rolling and why don't you know this?
Yeah, I can take on it because we spent a lot of time on this actually. So before we actually wrote a line of code to build our platform, we spent around 6 months across the state of New York in neighborhood senior centers for half days with older adults just to understand how they use Uber, Amazon, FaceTime with their kids or loved ones. Can they actually do any of that? Kind of understanding how technology flows into their day-to-day lives. What we learned was that the more you bring technology into the normal flow of people's experience, the more they trust it and the more they use it. One example I always use is this. When we were at the tail end of COVID and we started vaccinating people across the state, the first group were 80 plus and 70 plus years olds. And we actually required them to go and fill up 3 pages of forms on CVS website to get an appointment. If you have done it, you know how complicated that was. So when technology is designed bad, I would say it's designed bad ageless, and when it's designed good, it's designed good ageless. The way we solved for this was literally kind of figure out what modes of interaction older adults are the most comfortable with. Turns out everybody else is the same, text and voice. Like more and more, you guys are typing something into ChatGPT and it's giving you the answer. Guess what? A few years ago, you needed to flip through a bunch of pages of websites in order to get the same information, right? It's not people's fault if they get frustrated or they cannot go through that. We're doing the same thing, bringing everything through voice and text, making it usable within the devices people are comfortable with is probably the key to reduce the frustration, not just for older adults, but across the board.
Hi, I have a question from Ipset Vahia. So the watch you were talking about, how will it measure the medicine dosage that has been taken by the patient? And do the patients have to add the data manually or is there some other way?
Yeah. So we don't collect info. The device does not tell you what medication was taken and how much. That is part of the medical record. The device merely monitors changes in behavior that happen. So the device does not know if there's been a med change or not. Only the clinician does. All the device does, it's your regular fitness monitor. A smartwatch could do it. We like wearables like Fitbits or Garments because battery lasts a little longer and they're a little tougher. What it can tell you is whether someone's overall movement patterns changed, if their sleep patterns changed, if they were more active, less active over time. And then it's up to the clinician to make the connection between the change in behavior and the med changes that were made. And the older adults enter nothing. They put the thing on and then we take it off when they come back.
Okay, thank you. And with Nima Rohi, you were saying that there's a problem with the trust building. So why didn't you partner with the local CBOs for your,
We did. In fact, I mean, you saw a bunch of logos on my deck. Some of them are some well-known CBOs, such as God's Love with Deliver, or kind of large multi-state CBOs. But we, in fact, did partner with CBOs that were just serving 50 people, 50 older adults in a community. Turns out that those smaller CBOs are as sophisticated as the larger ones. They only are under-resourced. So one of the balancing acts that I think technology is doing and will do is basically bringing the same level of infrastructure, data-drivenness, and outcome-oriented interventions to those smaller CBOs that a lot of larger CBOs might have had for the past kind of 5 years or so.
Yeah, thank you very much.
Hi, thank you so much for the programs that you've implemented. I have a question. How do you integrate that with the older adults in the deaf community?
So it depends on which project we're talking about. So if that's of interest to you, one of our newer projects, Discover Live, actually can do that for blind and deaf. It's phenomenal types of things. That's a really difficult question. There's a difference in terms of implementation for visual impairments versus audio impairments, but I mean, I know Blooming Health does. All of them have closed caption ability, sign language interpreting. I mean, those are things that we provide on a regular basis for the hard of hearing community.
And is it streamlined to their cognitive deficits if they have any type of literacy issues?
Say again?
Is it streamlined
if you have
to
a hearing impairment and a literacy problem?
Yes.
That's an interesting question. Do you have a solution for that? No, I'm serious about that.
More awareness, education.
But what's the solution?
The solution is immersing yourself more into the deaf community and educating the different organizations or teams that have affiliations with those people.
Because I think it's a lot easier in a one-on-one group, face-to-face environment and a digital platform that becomes a little bit more difficult.
Right.
I can add something to that as well before we wrap up here. We actually, because having vision and hearing impairment is not really a binary problem, it's really a range problem. Like, you could have people having hearing impairment, and like sometimes you need to speak a little louder to your grandparents and speak a little slower, or they might not be able to read something you're texting them, so you need to give them a voice, etc. So one of the things we have tested quite a bit on really is that technology doesn't judge you, right? So what I mean by that is, like, technology can speak louder, it can speak slower, or send something you written instead of speaking to you if you don't understand what's being shared with you, right? And we're benefiting from that. We tested quite a bit of older adults to see when they have certain levels of hearing impairment, what tempo should the AI talk to them at, like what pace, what volume, because we have control over it. And it could speak a little slower, it could speak a little louder, and they could hear. If they're completely deaf, or if their vision impairment, they're completely blind, then I think that needs a little bit more special care, because it's not just about that engagement with them for us. It's about what intervention are we funneling to them, what service are we funneling to them. Some of those services needs to have the same level of kind of attention to it. One example of it is like when we funnel in transportation to the population, older adults that need transportation, we need to know whether the ride needs to be wheelchair appropriate or not. And the driver needs to know whether they need to go off and pick up the older adult, or they're going to show up to the car. So these are the kind of the value chain of services that you need to think about, adaptability and equity for those population along the way.
Thank you.
Hi, I have kind of an inside baseball question, kind of related to the funding streams for a program like Blooming Health. Is that something that's paid for typically at through state or city budgets, by the individual CBOs, or alternatively, considering the mitigated healthcare costs and the return on investments, is this something that you've been able to leverage with like healthcare companies to have like health insurances cover, services like that?
So for the projects, that 31 that we are funding, there's no cost to any end user or any organization. We fully subsidize. We are not fully subsidizing Blooming Health, although that's a goal. We tried to do that in the budget this year. So several of the projects, and again, I got to thank the governor when I asked her for $3 million a few years ago. Those are sustainable in the budget. They will keep going. To your bigger point, government usually doesn't do what we do. And I think, part of why I'm happy to be here, I know that NEMA is, I talk to a lot of other states, a lot of venture capitalists, a lot of investors. They're just not proactive. They're not, they're very reactive. We work with a lot of health plans. These are things that absolutely could be covered by mainstream, Medicare Advantage, MLTCs, Medicaid, and they're not. I think one of the things that I wanted to mention is these types of solutions are going to be that much more important come October. Senate's looking to cut $800 billion out of Medicaid, the House $660 billion, you're going to have $300 billion left in SNAP. These are things just on the table. 50% reduction in Section 202 and Section 8 housing. I could go on and on and on. And so when you're already looking at whether it be long-term care, health care, social services down 25% since coming back from the pandemic. One of the huge things in NEMA's data is our case managers are saving 2 hours a day. I mean, that is ridiculous, that these solutions are going to be, maybe more forced to be looked at. That's a positive thing if that happens because they work.
Yeah, one more thing I want to add to that is, I always say this, like if we were not started, we haven't started the company in New York, we probably wouldn't exist today. It's like some of the projects Greg is talking about, the support he has had for the kind of innovative approaches to some of the problems. This is not a repeatable commercial model for a company like us. Like meaning, there's only one Greg and New York Office for Aging. There's not many of them across the nation that would adopt technology this way. So to your point, we definitely are partnering with health systems and health plans, even in New York, like likes of Northwell Health and others, because they have skin in the game for this population, and the services we're facilitating to deliver actually cuts down on their costs. But bottom line is that most of this population are covered by Medicare and Medicaid, which Greg just talked about what's happening to it. So the risk exists there. We in fact had conversations with the state governors in the past few months. As this load is coming down from the federal government to the local level, we're going to overwhelm our social safety net at the local level. People are going to show up to the hospitals that don't have healthcare coverage or have minimal healthcare coverage. Yeah, or closed, exactly. So we're actually going to bankrupt our social safety nets, and the state governors are just literally panicking. How do we rebuild our infrastructure to be able to help these people and kind of have a backdrop for our social safety nets? If you're doing re-enrollment every 90 days, that's it's a lot of administrative work for the staff. Sure.
All right, that concludes our panel. Thank you guys very much. While we set up the stage very quickly, if people are going to start sneaking out since it's towards the end here, I wouldn't advise that because this is like the most important thing you're ever going to need to know in your life coming up next, so please don't leave. But if you do, in the interest of fiscal responsibility, because that's pretty important right now, please return your lanyards when you're walking out. And okay, we're just about set up. So the next panel brings everybody together. We've got older folks, seasoned folks, we got it, the people in the middle, and we have youth. So I'd like to invite Deborah Levine to please come up and to facilitate the next panel.
Hi, folks. Oh, my. Okay, let's try again. Hi, folks. Hey, okay, good. So I'm Deborah Levine. I am the Community Engagement Officer at the City University Graduate School of Public Health and Health Policy. Really quickly, by trade, I'm a clinical psychiatric social worker who happens to do public health. So if there's anyone else that's sitting in this sort of intersection, raise your hand, let me know. If I got some other folks in the house, there you go. Okay, great. This is going to sort of be a culmination of the conversations that we've had today. I'd like to invite our panelists to please come up and join us. Oh, Charles, that's you. Hey, come on. Where are my folks? Come on. They act like I'm here by myself today. Huh? No, wait, Charles, come sit next to me. Yeah, there you go. See, that's what you get for asking. You should not ask questions you really don't want the answers to, right? Miles? There you go. Okay. So I am fortunate enough to be able to be your moderator for this section. We're going to move through a series of questions to get a sense of what people have been thinking and feeling. What I am going to do is start with asking each of the panelists to give their names and just a little brief about who they are and, yeah, right, what you do. Yeah, right. There you go.
Hey, good afternoon, everybody. My name is Charles Johnson. I'm an attorney, educator. I work at Cornell University in the ILR school. I teach in the labor and employment law program. Just real quick about me, I served on as first vice chair for Community Board 10, was on the board for about almost a decade, worked with Deborah as well on all types of initiatives in Harlem. I'm a member of the NAACP Mid-Manhattan branch, where I serve as the civic engagement chair. I also sit on the state level for NAACP and work with my brother right here, Miles, on all types of stuff. So I'm excited to talk about these things. Also, it's weird because it says middle age, and I'm supposed to represent middle age, but I feel some type of way about that. And I'm sorry, but I feel some type of way about that because I just turned 40 this past December, so it's weird for me. No, don't clap, because it's weird for me. I'm in a weird transition stage. It's weird, though, but I'm definitely glad to be here and speak on behalf of millennials.
Hi, excuse me. I'm Jerry Ernst. I'm the Chief Population Health Officer at Immedicare. I'm a third-generation physician. I'm not aged. I'm not aging. We're all aging. I am 82, and I am proud of that. And I'm very sensitive to this. I was apprenticing to my father from the age of 10, so I've been taking care of patients for almost 70 years. And I have a lot to say about, I think this was an amazing conference, and I'm really here to talk about the place of compassion and the place of what we can do as clinicians, social workers, people who deal with this population with the help of digital tools, and also how we did this before digital tools. And I think the future, apart from what's going on in the country, but the future is bright in that we're going to overcome the difficulties clinical care has with managed care. We're going to overcome difficulties with doctors not having enough time with patients, using other devices and care managers and so forth. So I hope to get into that. Thank you.
Let's give him a round of applause, please. I mean, it's incredibly hard to follow one successful senior, that's Charles, but two is giving me the cake today. My name is Miles, well, good afternoon again. My name is Miles Hollingsworth. I'm an honors senior at Howard University in Washington, D.C., and I also have the privilege of humbly serving as president of the NAACP New York State Conference Youth and College Division. Thank you. particularly today, I'm more than proud to sit with two esteemed leaders in the community, but today's conference and this entire motif in this field is particularly important for this generation of which I represent, Gen Z and Gen Beta, Alpha, whatever's after me. I don't keep up with that. Because there's so many niche intersections that are not often brought to light, and that's my job as president of this civil rights organization, is to bring not only those items and motifs to light, but also equitably, so that not only are our young folk understanding what it is and fully accepting that torch of which is always being passed to us, but also doing so in a way that is competent and capable, knowing that they're not just receiving these tools and pieces of information about how to thrive as minorities in our community, but also knowing that there are real world sustainable tools, sustainable channels of aid, and sustainable networks of people of which we have at our foot and footsteps. So thank you. I'm excited to have it moderated by Deborah.
All right now. I'm gonna have to get through these quick, huh? Okay, so you can see that we have a very diverse panel here, spanning the lifespan, including the boomer sitting here. Did I say that out loud? Okay, all righty. So let me ask you this, Charles. From your perspective, what sort of generational gaps are most visible in the digital health design for access, trust, and training that you're seeing?
I'm glad you said that because I have some notes. I wouldn't be an attorney if I didn't have notes. Some of the gaps, so just to be clear too, when it comes to just Gen Z, one of our major concerns is data trust. If there are millennials here, you all can remember, we came into adulthood during the financial crisis, during data breaches. So we've seen all types of things. So I guess some of our major concerns when it comes to just the data trust is who's actually receiving this information. Is the information actually coming from, or when it comes to a health app, is it actually going to the doctor? Is it going to a data broker? Things of that nature. That's one of the biggest things that we see. I think when it comes to just bridging it, we want to see that transparency, that consistent driven data policies that we need. No hidden monetization, because I think we all see how that's taken a huge toll on just the digital industry, as well as just third-party sharing. Because again, we've seen how that's gone, awry, and how that can go to a negative space, though. And then also just trust building over convenience, because I think a lot of times they pitch, digital health applications, or just digital in general, as a convenient thing, but we're missing the trust component, the security component. So I think that those are some of the things that we can do. As far as just bridging the gaps, I do believe, and we have Gen Z to verify or whatnot too, and also I'm thinking of this from my nephews and little cousins that are Gen Z members, but I feel like Gen Z often trades privacy over speed, and I can understand that, but I think because of the experience that my generation has felt during that time period of just the transition, the golden age of this technology piece, is that they need to have a little bit more of the digital literacy support. And then when it comes to just baby boomers, just the trust the institution but fear the cyber crimes. And I think that we can help kind of bridge that gap.
Thank you. Miles, I got a question for you. As a youth leader and activist, how do younger generations experience the digital health system? And are these tools truly meeting the needs of our young folks?
That's a great question. I'm very glad that you asked that. In my perspective, both as a student in historically black college and university, but then also in my organization, I found through mostly conversation, but then most recently we've completed a survey of which young folk are responding to the health movement and particularly health tools in a lens that is from their either caretaker or in some cases lack thereof. And so in those instances in which there is not a caretaker or prime guardian who is responsible for those underage minors who are experiencing health tools, that's your first time at the doctor's appointment, that's your first time seeking therapy in school, your first time matriculating, translating your health records from high school or your pre-collegiate years towards your collegiate years or programs. Those interactions are not met with full understanding of what's happening right now. So in answering your question, it varies, that understanding. We're not seeing them able to grasp particularly what real tools are doing for them, right? Understanding what that is, right? I know that I can receive a text alert to my phone about prescriptions, signing off or on to HIPAA, and having that third or second or third party person present for those tools. That's not a full understanding that our young people are grasping right now, particularly because everybody loves to use big words, right? Everybody loves to use these tricky and legal jargon that often trips folks up. Why? Because it gets you more money. So the profitability fallacy that's there in this market is what's tripping up a lot of young people. What we can do and what I'm seeing come around that is a full breadth of understanding through education, right? Education is always a tool, but how are we doing that? And I'll be quick, is that it's showing up in schools now. Those seminars, particularly by campuses like NYU that the Department of Health is in tandem with, showing up in our preschools, our K through 12 education, but then also for those who are not in K through 12 education, saying that here at your local rec center, you're getting access and information to what is available in your community. That's working for people in bridging that gap.
Jerry, here's a question for you. As a leader in public health, how does Medicare use digital tools to close gaps in access to marginalized communities?
Sorry. We have a long history here, not just digital tools, but expanding the model of care. So our model of care has at its core care management or case managers. So in 10 years ago, we published an article in a peer-reviewed journal looking at our population, all of whom were HIV positive, those who had CD4 counts above 500, meaning that their immune system was fine, and those who had below that. And those who had below that, they were given the opportunity for targeted case management with that called COBRA case management. Those people got as much as they needed, as much as the COBRA case management said they needed, as much as the patient wanted, for as long as they did. That went on, and we showed that at the beginning, the difference between the T cells, those who were okay had T cells above 500. Those who needed targeted case management had T cells of mean of 175. Over 6 months, and then 6 months later, it went up to 475. And the difference was the targeted case management. We looked at also when COVID started recently, we expected our patients who now are not just HIV positive, but HIV negative people who are at risk, including transgender. We expected them to have difficulties getting to their care, getting their medications. So what we did, we asked for the staff to volunteer. We sent out text messages. We called patients, case managers called patients. We made over 7,500 calls. In the year following, we saw that the money we spent on antiretrovirals went up, did not go down. So our patients who had this extra help did better than they did before. And what we're showing now is that, we're not showing, we hope to show that with navigators, digital health navigators, who not only do what regular navigators do, but also teach patients how to use digital health tools and show them how telemedicine works, show them all the stuff that's available with digital health, they could do better. And the lesson from this comes from a partner of mine who's worked with me for 20 years. When the electronic medical record came along, he had a terrible time entering data in the electronic medical record. After 5 years, he retired. He couldn't do it. So there's studies out there showing that it's not a question of age. You need somebody to walk you through this and sit with you, and it has to be ongoing. It doesn't mean that doctors who had trouble, who were elevated in position, got scribes. The hospitals paid for scribes, so they didn't have to do this. People who worked intimately with patients in the clinic didn't have that. So they either quit or they adapted, or it was very difficult. So Medicaid can pay for that. It's part of case management, and thank God New York Medicaid is very good in paying for case management. Thank you very much. So this is something that really will help people who have language difficulties, because a lot of people don't, English is not their first language. People who don't have access, people who are afraid. Everything that you've heard today so well put as to the barriers. A study showed that navigators trained not just in health issues, but also in digital issues, improve the use of digital tools. I think that's very important.
Charles, what does an intergenerational digital health ecosystem look like in community? And one that's just not sort of theory-based, but really functions.
Okay, so I think that I think we really have to have an honest conversation when we're talking about just even generations, because if we break down the generations into demographics, because, how Caucasian, millennials have a different experience from Black and brown millennials, and same thing in all the various categories. Now, when I think of community, I'm just being biased. I'm thinking of Black and brown because of where I live, because I live in Harlem, and I think from my experience, because again, I was chair for public safety, so we did a lot of things with cybersecurity, Department of Health, not Department of Health, Homeland Security, just educating people. The NAACP, just the average age of the NAACP is 65 years old. So that's one of the things that Miles and I and other younger folks are working on to try to bridge that gap. So I think there needs to be honest conversations, and we need to be sitting all generations down first. And to recognize the commonalities that we share when it comes to digital health, because I think that a lot of the concerns that each generation has overlaps with the other ones. But in order for us to actually find that out, we have to have honest conversations about that. That's one piece. I think that we need to also utilize the experiences that the millennial group has experienced. I don't know if anyone listens to J. Cole, but J. Cole has a song called Middle Child. And that is the best representation of what I'm talking about, because right now at this age, at this weird age of 40, I'm realizing that my generation has a blend of the analog versus the digital piece. And I think that based on our experiences with, that Gen Z hasn't experienced yet, like, Cambridge Analytica, that whole crisis, that was our data that was exposed. Sharing our experiences, but then also identifying just what those commonalities are, and then identifying what the bridges are when it comes to education. Because I know I've heard this before about elderly people having the same amount of usage of technology as other generations. But I think if we really do a breakdown and look at Black and brown communities and just that access, we would see that there's a huge gap. Because the individuals that I speak to when I'm actually out there on the ground, and Dr. Smith can contest to this because we were on the board for years, there's people that don't have emails. You see what I'm saying? There's Black and brown people that do not have emails. When we talk about COVID, even we look at the access of COVID, there were Polo Grounds is a NYCHA building that's in Harlem. That's just one example of just the access to where there's not true outreach, because some people are actually afraid to have those conversations. So I do think that we need to have safe spaces. NYU, prime example of just having a roundtable discussion and including people that are representing those generations, but specifically finding the commonalities that we share, and then utilizing the strengths of each of the generations to how we kind of bridge it. I think that's the best way to start the ecosystem, but we have to start with real conversation.
Thank you. So that really brings up some interesting thoughts. Not only, it also reminds me that we have to train staff in being able to use these sort of digital health applications, because if we don't, then it puts us in another situation where we're sort of struggling to figure out how to make this work. So just as some of you are thinking about this, remember that training of staff is just as important as training the people we serve, so that people can be super comfortable with that. So thank you both for bringing that point up, because community health workers are extremely important and can be cross-trained to do not only the disease prevention work that they're looking at, but also making sure that they are super skilled in being able to use these digital applications. So thank you. Let me ask you this, Miles. Have you seen a moment when younger and older folks working together on a digital health solution, and what did that look like? I know the NAACP has been doing work over the years around intergenerational work and working specifically around health. Can you talk a little bit about what you've seen and how successful that's been with using an intergenerational model?
Absolutely. So I love the word intergenerational. It's like if I could get it tatted across my back, I would. In true Gen Z fashion, I took notes on this particular question. It's also my 21st birthday today, so I lost my... Thank you. And so forgive me on my brief answer, but my answer on this is our work in NAACP is truly, truly, truly groundbreaking. I'm thinking particularly not specifically on health, but in the same field, our recent partnership in New York State with Google. These awardees that we partnered with in tandem with Google were given access to these career certificates, which, as was just mentioned by our two colleagues here on the panel, gave that exact type of training that is necessary to explain, work in, and receive benefit from digital health tools. So this partnership was more than just giving a new career opportunity to those underserved and doing so equitably. It was also about recognizing gaps ahead of gaps, right? I see one puddle here. I love analogies, but I see one puddle here, but two puddles away from that, there's another puddle. So how can we address all three at once is what perspective we're taking in the NAACP through intergenerational leadership. Earlier this year, we actually buried our leader, my godmother and mentor, Dr. Hazelnell Dukes, groundbreaking pioneer in literally every field you could name. And she particularly would talk about the mattering of reading. And her favorite quote was that, for at least us in Harlem and across New York State, is that the emails she writes are written in English. So please read them. Although, of course, we interact with multiple languages across New York State, this particular dynamic of leadership, of me being able to pick up the phone sometimes 1, 2, 3 in the morning and call her, and vice versa, is what birthed a Google partnership. Google saw that, and they recognized that with full and open arms, which was able to reward us with an exclusive partnership, which resulted in these career certificates for these people who now work for companies like NYU, Northwell Health, and we've seen real-world results come from it, including more of an interest in these areas of life that they often discard. People who look and sound like Charles and I, and many in the crowd from. Like, STEM is a real aspect of which we're showing up. There are people who are black and brown and of minority races and ethnicities who want to work in this field and not be a doctor or nurse, right? And these career certificates, through that intergenerational partnership with Google that we announced, when was it, February of last year? Was one significant tool that we were able to produce. And I'm very proud of that, particularly because it quite literally really did take every hand, up from Miss Dukes being at the time 91 years old down to me at the time being 19 years old, which was crazy. So I'm proud of that, but particularly I want it to be a call to action, that there's real money in this field and in this conversation that needs to be tapped into. There's real people with power who have access to boost this conversation and not just be a, next year a one-day conference, but a 3-4 day conference. And that's something that we are trying to tap into now in terms of intergenerational conversations on digital health tools.
Thank you. Jerry, this one's for you. How do you balance the clinical promise of digital tools with the digital divide some of your patients may face, especially older adults or those with low health digital literacy?
Everybody in this room, I think, has empathy for the people they're engaged with. Compassion is when you do something about it. So when you sit with a patient and you have compassion and you see they have a problem like this, or they have a problem, they're illegal and they are on ADAPT and they can't get hepatitis C medications because they need a liver scan and they can't get a liver scan because they don't have all this kind. You get up and do something. And doctors and nurses and people in the community who have compassion do it. There's no excuse. You do it with digital too. You can do anything with compassion. My wife can't use a digital tool. Thank God we're married for so long. I have a little compassion and we're able to work that out. But it's not, our patients are patients who have all these social determinants who are all really, really vulnerable. They use smartphones. It's really a bias to think that they don't. It's a bias to think that just because their telephone number keeps changing, that they're fleeing something or whatnot. No, they have several phones, and they do many different things with these phones that we're not privy to. But they are in the digital world. There's a lot of stigma. There's a lot of crime that patients have. There's a lot of things that clinicians have to work with to get the patient over the threshold into the medical system. And you have to be very original when you're trying to approach that. The rule is it's what's best for your patient. That's the rule.
Gotcha. Thank you. Charles, what's one myth you'd like to bust about how your generation uses digital health?
A myth. I think one of the myths is that, I think one of the myths, if we're being 100% honest, is I don't think that we really acknowledge just the trauma, for lack of better words, that we experienced during the financial crisis and the data breaches and those things. So there's this kind of stigma that millennials are kind of, necessarily skeptical about technology. And I don't think that we're necessarily skeptical about technology. I think that we're just technology survivors, and I think that we understand the importance of not just having the technology there, but understanding the interconnection when it comes to health access versus digital access. And sometimes we just believe that just because we have digital access, then all of a sudden there's health access as far as equality is concerned, like health equality. I think that that's one of the pieces where it seems like we're kind of reluctant, or we might just be negative Nancy's about it. But I just think that based on our experience and based on what we've seen, we're just a little bit more mindful because, again, we have personal experience with it. And that's probably the best way I can answer that question.
Jerry, same question for you. Not as a physician or otherwise, but just as a human being, what's the one myth you'd like to bust about how your generation uses digital health?
I don't think we have a higher incidence of, well, that's not true either. We have illnesses in my generation that are in all generations that impair the ability to use digital tools. But I do not see any, for people who are capable, who have the cognitive ability to do this, I don't see a problem at all. I haven't, well, hey, I have password keepers because who the hell can remember 25 passwords? But I've had that forever, okay? And I lose my phones, but I've lost them forever. And I forget things, but I always forget things. It's not the, you're getting old. I broke my hip a year ago. And after that, I started falling when I walked up steps. And people, my family said, you gotta pay attention, Dad. You're getting old. You're falling, and you gotta pay attention. And the doctor says, think what you're doing. And my wife, we went for a walk, and she took a picture of how I'm walking. And we showed it to the physical therapist. Hey, your muscles on your leg are weak, the one that had this operation, which the surgeon never told me, hey, it's going to maybe a problem. And I strengthened the muscles, and it's gone. I haven't fallen for the past, not day, but past, for the past several months. So it's doable. You don't assume that because someone is old, not older, old, that they come with disabilities. There are other reasons that you have these disabilities. And what doctors do is if it's something, oh, we can't deal with that, it must be this. They don't investigate. But that's, you learn in medical school. If you have somebody with Parkinsonism who always has a stiff neck and he gets a fever and he's confused, you do a spinal tap because the stiff neck that's a sign of meningitis is no longer there. So you do the spinal tap because if you don't do it, it's going to die. You do it. You have to take these things into account. It's just compassion.
Thank you. Miles, same question. What's one myth you'd like to bust about how your generation uses digital health?
I'm so excited to answer this question, y'all. I want everyone to lock in with me. Not every young person is tech savvy. Not every person who is young is tech savvy. And what I mean by that is quite literally what I mean. Like, not every person is tech savvy to the point in which we often rest in our own class of this privilege to be tech savvy. I'm fortunate to have grown up on a school in Long Island where our first time in a computer lab was kindergarten. I have friends, people and team members who are working with us in NAACP who haven't touched a computer lab their entire school year, their entire school life, and they're now in college, and that's the first time they're seeing a conglomerate of technology in one room. That's almost unheard of now, but it was and it still is a reality for some of us in the state of New York and especially in the city. And so what I also want to dispel in that myth is that young people are also fluid and all over the conversation of life with technology. We're also not. I just flew in from DC not too long ago, and I had a doctor's appointment with a family member, and I was, looking in the doctor's eyes, and the doctor's looking at me. They're speaking to me, and it was like, I'm political science at Howard. Everything that was going in one ear was going right at the other, and I was researching like what I could do to like kind of follow up on that appointment. And before I knew it, my person in my family who was signed on to my HIPAA had received a text message about my prescription to pick up. So I'm like, thank God that we had that, because I would have been lost. And that's something that I do want to dispel, and rest assured there that oftentimes we're running into a class issue when we believe that everyone is tech savvy, especially young people. We're looking at, especially in NAACP, folks who have never had a phone until they turned 18 and started working, folks who haven't touched a computer or a MacBook, don't know what AirDrop is, none of that until they've gotten to college or a program or something. So that's what we're often trying to dispel, but that comes with conversation, and it comes with real education. I'm proud to lead that conversation at NAACP.
Thank you. We got 5 minutes. All righty. So we're going to do this. Okay. So you have the mic down there, so you hold on to this. What's one immediate step we can take to strengthen intergenerational trust in the digital health space?
That's a great question. It's a loaded question, but briefly, I think that our culmination of this conversation and of this conference intergenerationally looks like us recognizing that we're on the same page, right? Oftentimes, it's young people need to respect their adults, of which they do, and likewise, adults are respecting their younger counterparts, and these generations blend very nicely, as you guys can tell from this panel. And so, in our call to action, in my call to action, it's understand, number one, that we're on the same page, and number two, that it comes with us getting involved. Apathy is the opposition's greatest tool. They're counting on us to say that, you know what, those young folk are not into it, they don't understand, they're not hip to what I'm talking about. These are high-level conferences and conversations that are beside and, you know, over these young people. Let's move on. Let's refrain from that moving forward, and let's really root in the understanding that we all are on the same page. That requires all of us to be hands-on, and that's what NAACP leads in, and I'm proud of that.
Thank you. Jerry, really quickly, one sentence. What's your vision for the future when digital health bridges generations instead of dividing them? Sure. In one sentence, what's your vision for the future where digital health bridges generations instead of dividing them?
It's hard enough for me to get along with my 3 children and 8 grandchildren without digital health. We could use digital. Perhaps that would help us. I think there are many other things separating the generations, even in a family. I don't know.
Gotcha. Charles?
That's a tough one. Why'd you give us you gave Miles the
I'm making-
softball, right? Can you repeat the question so I can?
Sure. What's your vision for a future where digital health bridges generations instead of dividing them?
I think it goes back to inclusion, the empathy aspect, and really breaking down the smoke and mirrors of the fact that we are of different generations and focusing on a commonality of what is the issue. Because I think if you really look at this in this country, when you talk about how to divide people, the most simplest term too is think about race. They use race as a smoke and mirrors to avoid our commonality when it comes to our poverty. And that was something that Dr. King talked about in one of his last books. And I think that sentiment can be transferred over to all industries, including when it comes to health. Because again, a lot of us are too busy pointing the finger, like you said, oh, the older people don't know this, and the younger people don't know this, and the middle-aged people, it's crazy to tell, middle-aged people don't know this. But my point is that we have to get past the smoke and mirrors and focus on the commonality. I think that once we do that and start really addressing things, that's the way that we're able to do that.
So I think that's our 5 minutes, but I do have a closing statement, and that is just to be mindful that everybody doesn't have access to the hardware, a phone, a tablet. So we can talk about digital health and applications and all of that, but just be mindful that some of our communities are still struggling just to be able to get that. And even when they have it, it is limited in time and how much they actually can charge and where Wi-Fi is. So those are all considerations that we have to take in, whether you are a Gen Z, a Gen X, middle-aged, a boomer, or whatever you fall into that category. And I think the other thing is that, as everybody has sort of said, being gentle and kind, and if you are not the one that's good at instructing people and you get frustrated, maybe you're not the best teacher. And that's okay, because there's a lane for you in this process also. You could load it onto the actual phone or the tablet for them to be able to use. So I think that ends our panel, and I would like to thank our panelists, but most of all, thanking you for staying with us this afternoon.
So we'll just quickly open up to Q&A. If you guys have any questions, we have so many different perspectives. I'll start with a question that highlights a group that's not here, the really younger folks, so kids like 15 and under. A lot of times, those are the folks who are really doing that navigating and helping people who are older, especially with like, you know, a TikTok or just to explain what that is to an older generation. How do you individually manage your interaction with that specific age to not overburden them, in some cases, with being the facilitator of usage for these types of technologies?
For me personally, listen, my daughter is 12, so she constantly reminds me that, you know, of how old I am. But the other funny thing is, she said something to me when I think she was about 7. We were having a conversation, and then she asked me, she was like, "Daddy, you know, you guys didn't have Alexa?" So that just put in perspective, because I was talking about Encyclopedia Britannicas, like, and she was like, "What are you talking about? Why are all these books at Grandma's house?" And I was trying to explain to her, this is how we, you know, and then she asked the question about Alexa. So I think it's just also putting in perspective for them that they can't heavily rely on the tech, you know, because if something happens, you have to still be able to pick up a book and actually read it. So I think for us, when it comes to them not overburdening them, I think it's just making sure that there's a healthy balance to where there is access to the technology because they're naturally growing up in that world, but also bridging in and making sure that they understand where the connection and the nexus is and how you can retrieve that information if something from the internet doesn't work. Because if the internet's down, then what happens? You see what I'm saying? That's where these Encyclopedia Britannicas that I used to hate reading as a kid come into play. But them understanding that piece, and like I said, just not solely relying on them to be that bridge, because I think it's unfair. And also, too, they're impressionable, so this is our opportunity to educate them and educate my child as far as like what was the hurdles that we experience, you know, as this technology gets to the point where it's at right now. Just making sure that they understand the historical context and also making sure that they don't over-rely on that. Because even in law, I have a legal intern now that's constantly using ChatGPT, things of that nature, and I'm explaining to her how you have to use LexisNexis, you have to use Westlaw, you have to go through the actual process of researching legal documents and confirming whether precedent is relevant or not, because you can't just rely on tech, you know? And as we all see, just relying on AI and just relying on things like that, there's all types of flaws, but the only way that you can identify those flaws is by having that background foundation of how to properly do things. So I think it's just carrying that healthy balance.
So I would just say really quickly, we run a youth program during the summer where we actually train young people under the age of 16 to be community health workers for their peers. But, you know, anytime you train an individual, they're going to be that point of light in the community where others are attracted to them because they have knowledge. And so what we do is try to help set up healthy boundaries. So it's okay to download the app and maybe help them register, but really depending on the case manager and others to be able to engage in some of those more in-depth conversations, and figuring out where those boundaries are and having real conversations have become really critical in not making our young people the sole responsible person for following the app, opening the app, figuring out what the tabs are and how those things are. So really sort of going back and working with those providers to really work with the identified client to make sure that they are clear about how to use those. So that's one way that we've been able to do that. Thoughts, Jerry?
I have one of my grandson is going to be a junior who uses GPT for his papers. And we had a long discussion about the limitations and how maybe there's 100 articles that are important here, and ChatGPT only had 98 of them, and those 2 that weren't there. And eventually, and he understood that. And he listens and he changes. So you can use it, but you need to also do the back work to make sure that something hasn't been missing. So it's working with the person and being aware of what the dangers are and pointing them out. And if you have a good relationship, maybe they'll believe you, maybe.
So my question is actually looking at the frustration sometimes that individuals experience in engaging with digitized software, automation, and I'll give you an example. I have an 87-year-old aunt. She needs to have her New York State ID renewed. And I don't know if anybody here has had the issues of having a delay in getting access to an appointment with the New York State DMV because they give you a phone number and it's an automated response. You try to get a body to speak to and there's just no one there. And it happens a lot in a lot of healthcare systems where you need to get approval for certain things because it's not automated. You need to get a referral, right? So these are things that, you know, as we think about digital health and automation, there's that other part that it's like we really need to hold institutions responsible, that when they adopt automation, they need to do it in a responsible way, that they need to understand that they still have to be held accountable because there are people that, you know, when we talk about access and equity, there are people that are not getting it, not because they're not trying the systems, but because the system is not responsive to their needs. So I just want to put that out because I'm frustrated. I still didn't get her DMV license and I have to go back and figure it out. So.
That's a great point. Just to touch on that a little bit, I can relate because I also need to get my ID renewed, and I tried calling the DMV. I want to touch on a point that I hit a little earlier about these institutions, especially those with a little more history or money, whatever the case may be, intentionally putting those roadblocks in there on the basis of profit. You know, longer time on the automated call. Now we have to use that automated call more. That's, you know, a bigger expense for them. That's justification to ask for more money in X, Y, and Z department. That is what it ends up looking like on the back end of things. But that frustration crosses many barriers, including generations. I think it's, like you shared, incumbent upon the institution to realize that this is intentionally putting people at risk, and then also, you know, just not helpful. So let's start really looking at the bigger problem, which is putting profit over people, and zoom out a little bit and say, how can we streamline and be both, and, you know, balance your books, of course, but at no expense of an individual.
Hi, happy birthday, by the way.
Thank you.
Happy birthday. I have two questions. Is that okay? Okay. So first, for both of you, Miles and I'm sorry, what's your name? Charles. No. For you two, I just wanted to ask, what resources are there for community grassroots? Just to connect community with grassroots with companies like you guys and partnerships with telehealth providers so that we could just bridge the gap between the elderly and the youth. Because I'm realizing that a lot of third spaces are being diminished. They're being closed. Community centers are being closed. There's no barbecues. There's no community anymore. So the knowledge that's supposed to be passed down is not getting passed down because there's no spaces. Where are the programs? Where are they? The connectors. Yeah, where are the connectors? And are there opportunities for youth in certain communities, certain disproportionate communities, certain impoverished communities to become employees there, to connect maybe foster care, juvenile justice, just Black and brown communities?
It's a great question. I'm very happy that you shared that with us today, so thank you for that. I immediately jump in, you know, no self-promo, but a little self-promo, and say NAACP. First and foremost, we are an intergenerational organization, so in terms of connecting and seeing where we go from conversations and conferences like these towards grassroots and community activism, we are quite literally the epicenter for that, especially for folk who are in a oppressive space. And that's something that I'm very proud of, that we've created that culture there. As I shared, my mentor and godmother, Dr. Dukes, was 92 when she passed. We were on the phone chit-chatting up until, which was really inspiring for not only me, but other people to see as well, because that wasn't just a relationship we created in our nonprofit organization that translated into, you know, my admission at Howard University. It translated into our partnership with Google, our partnership with Microsoft. We have a couple of upcoming partnerships, which I can't share yet, but they're big, sweet partnerships, which are turning people from regular community members, which I believe I like to call them untapped power, into these people who are engaging with C-suites across the nation and across the world, really. So that's one area, but in context of this conversation and conference, I would say that these areas are trying to be pushed out by the government. It's just incumbent upon you folks like you and I to continue to raise our voice to say that we need more of this. As I shared a little bit earlier, this is a field that gets a lot of money and deserves a lot of money. Conferences like these should arise more. Opportunities like these should arise more. The Department of Health of New York State should be in more places, more niche corners. And that's something that, of course, with advocacy comes with that, but I'm positive our colleague and doctor right here would have more to add on that.
Just before Jerry answers, let me just say, like, folks like the AIDS Institute have these materials and they're online, and it's up to like the community-based organizations to help disseminate that information. So you have programs like Team Pact, HEAT, and other youth programs across the city that we are cross-training young people, not only to look at the disease that they are specializing in, but also thinking about ways to cross-train them in things like the digital health spaces and being able to use those kinds of tools that they're most comfortable with in being able to help that connection, which then in return, as we know, as they go home, they share that information with others in their families. So there are programs, they just may not be quite identified as like digital tech programs, but you see the integration of these kinds of technology and being able to help them better understand so that they in return can talk to their peers and others.
Yeah, I just want to add on to what Miles said too. Do you live in the city?
Yeah.
Okay, so the other thing, just on top of what Miles said, because all of that is absolutely true too, and shout out for the plug as well for NAACP, because he knows we worked on some great stuff and we're working on some great things. I would also suggest that you go out to your community boards. You could actually reach out to your district manager's office. You could actually reach out to identify what committees they have that cover technology. Example, in Central Harlem, we had our Economic Development and Technology Committee, which is one of the committees that meet monthly. And so you can go there and you can actually ask for local community organizations that are starting up or that are doing things that they're aware of, because typically what happens is when you're starting off like that, they'll go to the community boards and they'll have information. If you actually go to your district manager's offices, you'll see a plethora of stuff there. But I think that's one of the things to start off with as well, on top of what he said about the NAACP, because we do have a very strong foundation, as well as with our youth and college division, and then that transitioning over to the branches and working together to where we can bridge that. But I would definitely recommend starting with your community board and asking them, what are some of the local places? And then after going to your community board, then you go to your city council member as well. So you could really go up the chain from community board to your city council to your state assembly, and then ultimately to the borough president's office, depending on which borough you live in, because again, they have also access to those organizational names throughout, their respective borough.
I didn't think of that.
Good one.
I have one more question.
Okay, we have a minute, so.
Actually, it's okay.
No, come on.
So too, go ahead.
Okay, my other question is, if we have a community of young people in certain circumstances like foster care or that have been in jail, how do we get them to free technology and free resources that will get them jobs in these spaces? How do we get even access to like healthcare? Like, I have a large community of youth with HIV that don't have access to ART or protease inhibitors or NRTI, anything like that. They can't get that with, can they get that with Medicaid? How do I get them to
So I'm
go?
going to guide you right back to where we started, which was have a conversation with the local community-based organizations who specialize in HIV. AIDS Institute has a great resource on their website with a ton of community-based organizations across the entire state. Your local community boards, their Health and Human Services Subcommittee will have a list of organizations that have access. Again, you're going to have to do a little digging. It's not just going to sort of pop up. But if you're in a hospital, the local social worker in the hospital is also going to have some of those resources and know the best organizations to make those referrals to.
You said something that triggered too, and I work closely with this because you said reentry. You're talking about individuals with criminal records. That's one of the things that I actually teach in the Labor and Employment Law program about reentry, about criminal records, how even with the MRTA and other bills that have amended the labor laws, and now discrimination, or if you are an individual that was convicted with a record, you're now a protected class in New York State as far as with EEO. So to your point, though, I think that there's, going back to what Deborah mentioned before, just going back to the local community is one piece. There's also the DOE fund. You could do research as far as just re-entry programs throughout the city. And I think that would be at least the first entryway to trying to figure out exactly how you can get that access and to truly help people. But there are a multitude of organizations that literally focus on reentry, because what I hear from you is two separate categories. I hear the reentry issue when it comes to criminal records, as well as just the access when you're talking about HIV patients and things of that nature. You could split those up into two buckets and really identify who actually addresses recidivism and reentry programs, and that's one of the pieces. But again, you could start that off in your community board because they'll have access to directly the individuals there. I would also include the district attorney's offices, because I know for a fact Manhattan District Attorney's Office, they have programs that are specialized regarding reentry. So then they could lead you to an avenue as well. But going back to what Deborah said, you're gonna have to do a little bit of research on top of that. But that's where I would suggest that you start.
All right. Thank you, guys.
Hello? Okay, there we go. Thank you very much to the panelists and the moderator. That was a great conversation. I think we learned a lot, right? Let's give them a hand of applause. All right, we made it to the end. Yay. So attention spans is cited as being about 8 seconds. I'm going to ask you if you can give me 9 more minutes and stay with me. All right? All right. But you guys have been doing a great job today. I think the attention was really here. Lots of conversations, lots of comments and questions. That's awesome. All right, so here we go. As my child would say, this was a movie, okay? That's Gen Z for, right? Epic, powerful, and unforgettable. And today was all that and more. We came together across generations, professions, and lived experiences to explore how digital tools shape and improve health outcomes across every stage of life. Our goal today was to highlight how digital tools can bridge health disparities by addressing age-specific needs, closing the digital generation gap, and inspiring action to build more inclusive health outcomes. Our agenda reflected the journey from insights about lived experience and ethics to panels exploring how chatbots support or not support youth, digital applications for middle-aged adults, managing chronic conditions, and how older adults navigate care with assistive technologies. We closed with a powerful intergenerational fireside chat that reminded us health happens at every stage, right? And it should be that way for all digital inclusion and transformation. Across the sessions, one message rang clear. Digital health is not one size fits all, right? But it can be inclusive, impactful, and empowering.
When we listen to one another and build with intention, we saw that during the working sessions, it's powerful. Youth voices reminded us that they're not just clicking, they're critically thinking. As the young folks shared today, we don't just trust everything we see. We research, we cross-check, we know misinformation exists online. That level of digital discernment signals a generation ready to advocate, create, and lead, especially when equipped with the right tools and trusted spaces. Older adults spoke with clarity and wisdom. Many shared the emotional tools of feeling left behind by technology, especially when trying to age in place. They reminded us that access must come with trust, usability, and compassion. We also heard that having digital navigators, these are supportive guides who can walk a patient through digital tools. We heard that with Greg Olson, can create a more inclusive and inviting space for older adults and others to learn on their own pace. Let's remember that everyone has challenges with digital tools, as Miles mentioned, right? It's not just young people, just old people, it's young people too, right? And success lies in how we support each other. The middle-aged participants offered equal important insights, the life stage of juggling careers, caregiving, and personal health, can live little to none when learning new technology. But there was a clear interest in better digital tools along with caution around privacy and data protection. Concerns about how personal health data is collected, stored, and potentially misused came through loud and clear. Transparency matters, and our solutions must reflect that. Working across generations isn't always easy. We heard it during the conversations just now. Patience is sometimes a short supply, and older adults don't want to feel dependent on youth to navigate digital tools. But the tension also revealed possibility when we center mutual respect, share goals, and collaboration. So what did we do to take home from here? Not just ideas, but actions. If you're a provider, consider how tools work for someone that's older and younger than you. Have you tested them across the age groups? If you're a public health, or if you're in public health or in policy, are you designing with equity in mind, accessibility, and privacy in mind? If you're an educator or an advocate, use these insights to spark conversation, guide programs, and co-create with your community. If you're a technologist, view your user journey through a lens of lived experience across generations, languages, and abilities. Let's move from knowing to doing. All right, where is this thing? Saying thank yous. So thank you to all of our incredible speakers, panelists, moderators, workshop leaders. Thank you for your passion and your perspectives. To the dedicated volunteers, you kept the day moving seamlessly. To our youth, your honesty and your clarity were some of the day's most powerful contributions. So thank you very much. To our sponsors, the Conrad Hilton Foundation and vendors, thank you for supporting this event. To the Digital Health Initiative team, your creativity, your commitment, and hard work made today possible. Yes. To Dr. Cheryl Smith for her continued vision and leadership in advancing the integration of this work across our organization. Thank you. And to you, our audience, thank you for showing up, engaging fully, and keeping your minds open to the possibilities of digital transformation. Thank you all. 2 more minutes. All right, so the last thing is what's next. Complete the conference survey. Your feedback helps us to grow. This is our second annual conference, and because of the feedback, we were able to do something like this today. Visit our website. You'll find session recaps, action items for each of the sessions, and then resources. I know many of you have come up to me and other staff members asking about the PowerPoint presentations. They may not be there right now, but they will be eventually. Continue the conversation on our conference forum. I don't know if people got a chance to go in the live conference forum today, but we really would love to hear your thoughts, reflections. Drop an emoji, like I said earlier. That will be great about how you felt about this experience today. And then finally, let's keep the momentum going. Whether you're young, middle-aged, older, navigating digital health tools is now an essential part of our lives. Let's make sure that the tools reflect these needs, strengths, and voices of every generation, because we all deserve access, safety, and support. Thank you again, and we hope to see you next year. Can you please come to the step and repeat so we can take some pictures? I'm going to repeat that again. If any of the speakers or panelists are still here, moderators, can you please step over to the step and repeat so that we can take pictures? Thank you.